I just want to take a moment to welcome everyone. I'm Cindy Mers. I am part of the leadership team at Suburban Hospital, and I am so honored that you all took some time out of your day, especially on a beautiful Saturday, to be here to focus on this really important topic of mental health and mental wellness, and especially how it impacts our young people and our older adult populations, which is what we're focusing on today. So I am so grateful for the experts who have come here today to join us, and you're going to learn a little bit more about them in a couple of moments. But I'm also honored to have the man beside me join me here at the podium, who has made this program possible with a generous family endowment. And Mr. McMahon, along with his family, is doing an amazing job through this program and other efforts to really keep the memory of his granddaughter alive. And I'm going to give him a moment to tell you why this is so important to him and his family.
Thank you, Cindy. Good morning, and I'm John McMahon, Tara's grandfather. It was she was a joy to have all my granddaughters. We did everything together. It was just enormously fun to be around her. She was a live wire, full of life. She was a champion in equestrian. She competed on a horse and won most of her meets. That was in the 100 jumper class, which is don't knock anything down and how fast can you go. And she was really good at it. And I could actually see the expression on her face when she knew she had to make up some time. And the horse knew it. That horse said, if she had that look on her face, the horse knew it. I don't know how, but they do know things like that. She was a joy to be around. And so the fact that I got to know her and got to be so close to her and have all the fun times, that's what I have taken away. But then to get, a phone call to find out she had terminated her own life, and it was stunning, to say the least. And there's nothing that can ever fill that hole. Every room I have, there's a picture of the family, and Tara's in it. And so this is constantly with me. But what I was going through, we as adults, we're kind of the age where we're raising teenagers and taking care of elderly parents. Well, this seminar is going to hit both topics. But we will never be able to outsmart our kids. I learned that because I tried when they were growing up, and they always saw through me and did an end run. So that's the challenge. We are kind of clueless as to what the newest thing for kids are. So hopefully we have some experts here that can clue us in, and it's well worth knowing what they are all about. So that's what's kind of this brings us here. But I just think the community should know what's going on in our high schools with our kids and dealing with older folks. And so this is this symposium is to discuss all that and answer any questions that you all may have. So thank you.
And now I have the honor, first again, I just want to say thank you to Mr. McMahon and his family, and I'm so grateful for him sharing a little bit of his story. It's obviously been a great impetus to help educate the community, and that's a fantastic opportunity for all of us. And again, thank you all so much for being here. So now I have the honor to turn the program over to Dr. Ashley Bone, who leads all of behavioral health sciences here at Suburban Hospital, and she is going to take you through the program and introduce you to the experts that we have here. And again, we're going to have, she'll tell you all the ins and outs of what we have to offer today. So thank you so much for being here, and without further ado, Dr. Bone.
This is a day where we get to educate people on various topics each year, but this day actually has become very personal to me. And you know, I was given the gift of choosing speakers each year for this symposium, and I want to hear people that I want to hear. So I feel very fortunate. I get to pick some amazing people to come and talk with you all. And each year, I've just loved it each year, and I think it gets better and better each year. And that's partly because of what people bring. It's partly because of you all and what you bring, and the various questions and things that you ask about. So I think part of this is cerebral, you know, educating people and all of that. But I want to make sure that we're reminded of the humanness of it all. And so I'm going to introduce our first speaker, Dr. Roy. I'll give you her stats, her credentials, you know, all of that. But I want to just share a personal story as well, so that you know what an impact Dr. Roy has had on my life. Dr. Roy, I have known her actually for, we just figured it out, like 14 years now. And she actually currently is a huge leader in neuropsychiatry at Johns Hopkins. I mean, she is the medical director of Johns Hopkins Bayview Neuropsychiatry Clinic. She's the director of the psychiatry interns that are at Bayview. So she really is involved in education. In addition to that, she's also the director of the Consult Liaison Service at Bayview, which means that she deals with very medically complicated individuals, but also complex psychiatric cases. So she's really passionate about this crossover with complex medical cases and psychiatric cases. She's very involved in the education of our future doctors. But more personally, I will just say that I started working with Dr. Roy when I actually was the director of the Consult Liaison Service at Bayview. And at that time, I was young and really arrogant. I'm not young anymore. I might still be arrogant, I don't know. But I was a new mom. And I was trying to figure out how to be a new mom and work. And I didn't really know how to do that. And I kind of got pulled into this idea that, well, women can't be leaders if they're moms. And I had this huge conflict. And what was even more interesting is Dr. Roy came into a fellowship that we had just started for Consult Liaison Psychiatry. I had never done this fellowship. I didn't do it. In order to train, I went through Hopkins residency, and so I kind of felt underqualified to educate her. I felt like, I don't know, I mean, she's in this specialized program. I did a Hopkins residency, but I didn't do this fellowship. And she pushed me in ways that she doesn't even know she pushed me. And it actually allowed me to recognize, yeah, I actually can do everything. Like, we can try that. And we can try and be a leader, and we can try and be a mom, and we can be involved with the kids, and that might mean changing jobs and moving closer to home, and which is really what got me down here. So I'm just so appreciative that Dr. Roy is still an integral part of my life. She also sees patients here at Suburban Hospital on weekends, and fortunately not this weekend. We had to shuffle that around. But she's going to talk to you about geriatric psychiatry, and it's a very broad category, but she's going to talk about mental health related to that, but also some cognitive issues as well.
Thank you so much. I always stand up here and say almost all of what I know about consultation liaison psychiatry started from Ashley, and Dr. Bone has been such an integral part of my life as well. And I hope today I can transmit a lot of that knowledge to many of you. So I'm going to explore today the area of aging and how we can walk out of this room truly being able to appreciate this particular population of individuals and how meaningful this group is to us in society. I have one disclosure. My research in traumatic brain injury and neuropsychiatry is currently funded by the Behavior Research Foundation, but I won't be talking about my research today specifically. I just wanted to put that out. So when you walk out of this room today, there's three things I really want to make sure we kind of drive home and make sure everyone has a good understanding about. The first is to identify common psychiatric conditions that tend to occur in late life. There are many, and I don't have, an entire hour and a half to talk about them. I only have 50 minutes to talk. So we're really going to pare it down to three big buckets of things that we see clinically very often. And within that, with neurocognitive disorders and mood disorders, being able to come out of this talk today understanding what are some of the symptoms that you want to be looking out for in a family member, in yourself potentially if you are at risk, in community members. And not to get too much, we're not trying to make psychiatrists out of the audience today, but at least walking away with a broad sense of what are some of the interventions that we use generally in the mental health community to help treat some of these conditions in late life. So why is it important to start off talking about the aging population, and what is it particularly that makes this group so special? Well, if you think about sort of the trajectory of where we are going in society, it is the most rapid, developing, rapidly populating group of individuals. So by 2050, at least 1 in 6 people will be above the age of 65 years old. And so what does that mean sort of from a societal perspective? So if you take a look at the proportion of individuals that are aging above the age of 65, and per 100 people, the number of people who are between the ages of 15 and, let's say, 64, that old age dependency ratio is growing, which means there's a larger number of individuals who are going to be ending up caring for this particular group of people. Now, as we get older, things start to change for us in many ways. First, physical. So we start to sort of notice, our hearing goes, or our eyesight changes, or our bones begin a little bit more brittle, so we're more likely to have injuries. So physical impairment can also lead to a lot of functional impairment. Then you combine that with potentially mental disorders or psychiatric conditions that can further add to this picture. And then that third layer is when we have medical comorbidities, high blood pressure, diabetes, asthma, things that end up bringing us to the hospital and getting medical care. So these 3 different layers really globally add to the functional impairment that can particularly affect people in the aging population, as well as sort of disability impairment as well. So why do psychiatric conditions in this particular group matter? Well, the first is it's a really important area of exploration now, and a large percentage of people are starting to develop more and more conditions. At least 14.1% of adults age 70 and over will have some kind of a mental disorder. And this then accounts for about 6% of total lives lived with disability. So if you add the years lived that along a trajectory of one's life, if you compound it with mental disorders or psychiatric conditions, that accounts for 6.8%. Depression and anxiety are very highly prevalent in older adults. We're going to focus on the 3 big buckets today, depression being one of them, but it's important to know that these are signs and symptoms that really need to be recognized early and caught early. And about 1/6 of the deaths that occur from suicide occur in those that are age 70 and above. So again, not something to be taken lightly and something very important to recognize. What are some of the contributors of these things? Well, depression, anxiety, how do these sort of play a role, and what are the elements that play a role in this? And there's a big area in the field of this discussion of the social determinants of health. What are some of the contributions within this that impact mental health? The first is sort of the social determinants of overall health. So this is, as I mentioned, when we develop medical conditions. As people age, there are high risk for diabetes, hypertension, high cholesterol, et cetera. When people age, there are changes to access to health care. Insurance policies change, coverage for medications change, access to certain facilities and ability to have in-home health care changes. Then there's this concept of caregiver burden. We have this generation of adults who are taking care of young children as well as older adults, and they are also burdened to take care of 2 sides of the family member. So these overall health influences are really important to think about. Then we have the social determinants of mental health. So there's constantly stigma of mental illness. In the aging population, many come from a generation where they don't want to accept that there was some kind of a mental disorder or psychiatric condition. Depression is something you can just kind of walk it off and get over. So there's a stigma against that. Then there's mental health disparity. We very well know that there are certain populations of individuals who really don't have access to care like others do. There's a potentially flawed criminal justice system. And then there's a rising amount of homelessness that we have to worry about. Individuals who may have been veterans that now have very difficult access to housing, or Potentially, they were institutionalized when they had chronic psychiatric illness when they were younger, and now they don't have access to those housing services that they may have when they're no longer institutionalized. Ageism is also a real thing. People have discrimination against them because of how old they are. They don't have the ability to access the workforce like they used to. And then when they want to go back and work, let's say they had plans to retire, but then they end up changing their mind, they want to go back and work, oftentimes there's workforce shortages and there's not jobs available. And finally, there's this idea of social isolation and loneliness, because in this particular group of individuals, as we're aging, our friends also age, and many times there are individuals that have close friends who are dying or who are at the end of their life, or their own children go off and have their own lives. And so isolation, loneliness, and sort of withdrawal are a big part of what drives the social determinants of health within the aging. But there's a positive to this. Now, historically, we, as a society have viewed the aging population in various ways, in various capacities. And there has been this concept of there's a burden, there's sort of like this increased amount of risk, or there's an increased amount of concern for this particular population. But one thing that we have to think about is the positives that our older adults bring. They have lived experiences that have therefore given them wisdom that they can pass on to other generations. They've gone through many adverse experiences that have given them resilience to keep moving things forward and teach younger generations about what resilience actually means. And they put these together to really appreciate and provide a meaning in life that I'm going to be driving home today as a very key factor in what's going to help wellness in older age as people get older. So these are some of the things we want to make sure that we think about. What does successful aging look like? It's a very normal process, and it's something that we should strive to achieve in all of our patients and in all of the people that we care for. And what that really looks like is a subjective sense of well-being, sort of living life with very low perceived stress, trying to make things easier for yourself as you go day to day. Flourishing, which is a very big concept that we're exploring at Hopkins under one of our foundations that looking at the meaning of life and social relationships, and particularly in psychiatry, we're looking at specific patient populations. What does this mean for, allowing individuals to find connection and to find meaning in what they do? Successful aging looks like post-traumatic growth as well, having had adverse experiences in your past and then being able to sort of work through that and not necessarily recover, but build the resilience to move forward. And then if there is a diagnosable mental disorder, being able to sustain some kind of remission. And I often tell patients, our goal is not just to get you better, but it's to keep you better. It's for you to be able to live the life that you envision and that you want to live. Now, along with successful aging comes cognitive aging. Cognitive aging is a very normal, natural process. What happens to our brains as we get older? It's ubiquitous among every individual. As we get older, there are areas where we start to get more forgetful in. An example of this would be, hey, I used to remember how to get to this place without a GPS, and now I think I don't remember that address, let me punch it into my GPS a little bit more. Or I used to remember this recipe, I don't. So mild changes in, memory and cognition that start to happen. This can impact social functioning, because imagine the individual who is part of a social club and has been going for years, but then suddenly forgets the name of someone he's known for a long time. That can start to make that person feel kind of, vulnerable and kind of demoralized and not want to go to those social events anymore. The two areas that really get effective in normal cognitive aging are memory, and in particular episodic memory. What that means is memory of life events that have happened to you, that you have experienced on your own. And executive function. This is sort of what is the planning ability of somebody? I'm going to get up today, I'm going to go get dressed, I'm going to have breakfast, I'm going to go out and go to the garden and garden my lawn. Those sort of planning aspects of things are also things that can definitely be affected in normal cognitive aging. And because this is, again, a normal human process, we don't treat it necessarily with medications. This is where we do behavioral interventions, exercise, good diet, making sure people are socially connected with individuals constantly. Where it does sort of get what we call pathologic is when that normal process sort of gets derailed, usually because of a biological condition, but many times, as I mentioned, from social determinants and other environmental influences. So I don't have all the time today to talk about every psychiatric condition in geriatric mental health, but I'm going to talk about two big buckets of what we as psychiatrists see the most commonly and things that you're most likely to encounter in individuals in the community. The first are neurocognitive disorders, and so this is areas in which cognition, memory, thinking, planning gets affected. And the second are mood disorders. This is where we talk about how someone's affective state or mood state is. Within neurocognitive disorders, the two most common things we see are dementia and delirium, and I'm going to kind of outline the distinct differences between the two. And within mood disorders, we typically see late life depression as affecting and plaguing the aging population the most. So we'll start first with neurocognitive disorders. The most common being dementia. So neurocognitive disorders, as we'll talk about today, exist on a spectrum. You can go from very mild impairments in memory and processing speed and executive function to very severe impairments in completely needing full assistance in your day-to-day living. Dementia comes from the Latin word demens, which is us being out of one's mind. And the National Institute of Aging and the National Institute of the Alzheimer's Association, many have developed definitions of what dementia actually means. But overall, it's a chronic, global, and this is the key piece here, non-reversible. In other words, it's a neurodegenerative disorder that's not reversible, deterioration in cognitive function, usually in memory, in executive function, and oftentimes in personality changes. And you can see I have a picture here. On the right side is a patient without dementia, so I don't ever like to use the word normal brain because brains are very, very, very diverse in all their ways. But this is a patient with not having dementia versus on the other side, someone whose brain that does have dementia. So what's the key thing to know about dementia epidemiology? Well, 4 million Americans suffer from some form of dementia in some capacity. And it's diagnosed in at least 10% of all people over the age of 65. It's usually diagnosed in up to half of those above the age of 85. So as you get older, the risk of dementia increases. Again, it's a neurodegenerative disorder, so the risk is higher as you get older. And about 19 million Americans have a family member with Alzheimer's dementia. I'm going to focus on Alzheimer's today because that is the most common form of dementia, but at least 19 million Americans have some blood relative that has Alzheimer's dementia. And about 360,000 cases of AD or Alzheimer's dementia are diagnosed annually. Now, one thing that's really important from a systems perspective, this is a very expensive syndrome because if you look at per patient, per cost in nursing home care, annually it ranges from $42,000 to $70,000 per year. So it's really a very costly, extracting a lot of resources type of illness that we really need to put on the forefront and understand. So if we think about dementia, it's really important to think of everything, like we do for most illnesses, on a spectrum, right? So on the farthest end of the spectrum is what we call the mild changes in impairment that I was talking about before. This is, again, I need a GPS to get to this place. I don't remember exactly how to do this recipe. I can't remember this person's name as well. I'm trying to forget this person that I met a couple years ago, those kinds of things. But with mild cognitive impairment, you're still able to get up every day and dress yourself. You can still take a shower. You can still cook your meals. Your functional impairment has not yet arrived. So when you don't have any impairment in functional activities of daily living, it's still in the realm of mild cognitive impairment. Once those activities of daily living get compromised and you can no longer start taking care of those needs, that's when we hit the threshold of dementia. And dementia in and of itself has a spectrum of mild, moderate, and severe, which we'll talk about. So when you look at the spectrum of cognitive impairment and you compare it to functional impairment, we can see that there's also a proportional trajectory of change. So in the far end, we have what we call the preclinical signs. This is sort of the silent phase. The brain is changing biologically years before we actually see any kind of memory or functional changes occurring. So there are biological processes happening 10 to 20 years before we actually see measurable symptoms. And this is where the individual may notice things, but it's really not detectable on memory tests. And typically in clinical practice, we say this is the stage where the patient knows, but the doctor really doesn't. And Once you continue to move towards sort of the cognitive changes that are noticeable then, like I talked about before, mild memory loss, this is where you start to get into the MCI or mild cognitive impairment. But again, your activities of daily living are preserved. And then as you continue to progress, dementia happens when your everyday abilities start to deteriorate. So it's not just a spectrum of cognitive impairment, but now you're looking at a spectrum of functional decline. And finally, the third clinical piece is the behavioral. And this is what we as psychiatrists often, especially on the consultation liaison floors, get called for, is when there is a significant decline in functioning and in cognition, then you're also going to start to see behavioral changes. So as both progress, we start to see people get more agitated, more irritable, sometimes apathetic. And so again, there's a sort of proportional relationship here. So the more cognitively impaired, the more functionally impaired, the more likely to have behavioral impairment. And we have all these fancy scales that we use, the clinical dementia rating scale, the mild behavioral impairment checklist, et cetera, all these fancy little things that we use. But at the end of the day, we're really measuring the changes in function and cognition to sort of gauge how behavior is going to be impacted. So dementia, really this umbrella term used to describe a range of symptoms associated with cognitive impairment. And there are 4 subtypes that are very common. I'm not going to talk about all of them, Alzheimer's being the first, and we'll delve into that more. But I do want people to be aware about the other 3 areas that we commonly see. Vascular dementia accounts for about 20 to 30% of individuals, and these are folks who typically have cerebrovascular changes, strokes, et cetera. Lewy body dementia is another one that people often encounter. This has clinical features similar to Parkinson's disease, but has that element of really severe neurocognition and changes in sort of alertness and orientation. And then frontotemporal dementia, and apologies for the typo there, this actually came from a dementia foundation that they didn't catch the AL, but basically frontotemporal dementia is where there's specifically in the frontal areas of the brain, there's rapid shrinking of that area of the brain. But we're going to focus today mostly on Alzheimer's because that is the area that we have the most robust advancement in the science as well as in the clinical diagnosis. So Alzheimer's is the most common form of dementia, and it accounts for about 60 to 70% of all dementia cases. If you look at all the leading causes in the U.S. of death, Alzheimer's dementia is actually the 6th leading cause. And it affects 6 million people, at least 6 million people or more in the US. There are many different subtypes of dementia, of Alzheimer's dementia, but the most common one is what we call the progressive amnestic phenotype. That means it's those episodic memories, those experiences of lived life that are starting to get lost in this particular phenotype of dementia. And as you can see from this graph here, the trajectory from 2010 all the way to what we predict for 2050, the rates are just going to continue to decline unless we are diagnosing and intervening much earlier. So as I mentioned before, everything's on a spectrum, so mild, moderate, and severe. The mild kind of state of dementia, and again, by the time you've hit the word dementia, you're not functioning anymore, right? So your activities of daily living are now impaired. This is where we're going to see people starting to get, lost, going places. We hear about family members leaving the house, wandering the neighborhood, not knowing where they are, repeating questions many times. When you start progressing to more moderate, this is where there are individuals who are starting to have problems recognizing friends and even family members that they've known for years. There's impulsive behaviors that we start to see, very erratic spending or kind of going out and talking to people you don't know and you're in the grocery store. And one of the things that we often get consulted on, and is a very early sign that things are about to get much worse, is paranoia. This is where you'll start to hear individuals say, my sister is stealing thousands of dollars from my bank account, or I have to sleep with my purse at night because my daughter's going to come and snatch it from me. So that's when you start to know you've hit that moderate threshold. And by the time you hit severe dementia, this is where they're full assist, and individuals need to be in a nursing care facility where they need a complete 24-hour nursing care sort of supervision to manage all of their daily needs. So where we're going in the field of Alzheimer's dementia is some of the things that are same is we're going to continue to use these clinical signs to make the diagnosis. Go to the doctor, tell the doctor what your family member is going through. But where we are actually having a change and kind of we're in a fork in the road and really advancing the field is the use of more specific tests to say, yep, this is Alzheimer's dementia. You're giving me the clinical symptoms, but here's what's actually going on in their body biochemically. So using biomarkers to make the diagnosis. Really 3 big buckets of biomarkers that we can use are things that we can pull from the body and test in a lab and say, yep, that is that particular disease. And for Alzheimer's dementia, the three areas are from the cerebrospinal fluid, that's the fluid that sort of coats the CNS, the central nervous system, and we typically do what we call a lumbar puncture, go into the spine, pull out some of the fluid from the cerebrospinal area, and then test it. We do neuroimaging. We can take a look at people's brains, do specific advanced brain scans to look at areas, and then check the blood. There are specific blood biomarkers that we can sort of detect. With Alzheimer's dementia, the two elements that we really look for are something called amyloid and something called tau. And if they are abnormal, then we could say this very likely is Alzheimer's dementia. So when we do fluid biomarkers in Alzheimer's disease, we, again, pull from the CSF and we take a look and say there are low levels of amyloid. We can look at tau, which is another protein that causes a lot of brain changes and sort of memory loss, in particular when it's specifically in areas of the brain that are responsible for memory. And in the cerebrospinal fluid, again, we have elevated levels of tau. And we can also even check them in the blood. We're really advancing in the area of neuroimaging, and we've got a lot of work that we're doing at Bayview and generally in our Department of Neuropsychiatry and Geriatric Psychiatry, but particularly there's a specific fancy scan called the PET scan, and that detects really the metabolism of the brain. And in Alzheimer's dementia, we're really now noticing that PET scans can detect Alzheimer's dementia based on what parts of the brain are active and what parts aren't. And it can differentiate Alzheimer's from other types of dementias like frontotemporal, et cetera. Because, when somebody comes with memory loss and you say, okay, this is dementia, how do you know it's Alzheimer's versus frontotemporal versus Parkinson's? The treatments are always going to be different. So it's important to be very precise in how we're doing this and moving towards precision medicine. And you could see here, these are some of the pictures that we noticed that we have found in some studies that represent different areas of the brain that are under-metabolized, that represent specific deficits that you see in language, in behavior, in visual function, in memory, et cetera. And most recently, the FDA approved one specific type of PET imaging to look at specifically tau, to say, yep, this is Alzheimer's dementia. And amyloid PET is something that now we're also looking at. We're only using it in research studies, but eventually, hopefully in clinical practice, to say this is really what can confirm the diagnosis of dementia. As I mentioned before, it's really important to know that in particular with Alzheimer's dementia, that again, it's a process that's happening way before we see the symptoms. So 10 to 20 years, you could see in all the graphs, the orange line, the blue line, the red line, the pink line, these are all sort of the neuropathological changes that are happening that far precede the clinical signs, which is the green sort of, or the green curve there, which is where the memory and the changes in behavior and symptoms are happening. That's really important to know that by the time the clinical symptoms emerge, lots has been going on in the brain prior to that. So how do we sort of tackle this in terms of management, and how do we address dementia care? This can really be broken down into 4 pillars. We're looking at their cognitive symptoms and hopefully treating those, treating the behavioral symptoms, really providing patient support, and then medical management of disease. At Johns Hopkins Bayview, we have the Memory and Alzheimer's Treatment Center, which essentially encompasses this entire sort of multidisciplinary approach of what we need in these individuals. The first is really management of the cognitive symptoms. So the part of that is managing their medical issues, because if your high blood pressure isn't really well treated or your diabetes isn't treated, you can still continue to persist with these memory problems. I'm going to talk about delirium shortly, but we want to make sure that people who are delirious also don't continue to maintain, they don't have that propensity to become delirious if they, let's say, get hospitalized medically. And then there are certain drugs that we can use, particularly agents called cholinesterase inhibitors. These are agents that are particularly looking at a specific neurochemical in the brain that's responsible for Alzheimer's dementia, acetylcholine. And one of the most emerging agents that we have now, and really in the cutting edge area of the field, are these areas of monoclonal antibodies. We know that dementia's pathology lies on the fact that we've got these little amyloid plaques just building up in the brain. So these antibodies go and they sort of attack those plaques and break them up. At Johns Hopkins Bayview, we are looking at one specific one, lecanemab, Leqembi, and we give infusions to patients who have a diagnosis of amyloid or of Alzheimer's dementia there. And you can see on this right-hand side, there's a study that has showed with people who do get Leqembi infusions that those amyloid plaques actually decline. So this is really a very promising and cutting-edge area in the field of Alzheimer's care that's important. We also want to look at the second pillar, which is management of behavioral symptoms. As a consultation liaison psychiatrist, and I know Dr. Bone can attest to this, we are oftentimes really consulted for this thing. It's somebody's getting agitated, or somebody's very paranoid, or they are not engaging in care because they're very apathetic. So these are the things that we really want to treat, especially the psychiatry side of things, to make sure things get better. Patient support is very important. I can't emphasize enough that it's not just about treating the patient, it's about helping and treating the family as well. In terms of allowing the family to understand what are the resources that need to be put into place, what are some of the environmental changes that you can do. The first is getting your body moving, so individual exercise and stimulating the brain. I always tell patients what's good for the heart is good for the brain, so keep your blood vessels moving. Cognitive stimulation therapy, I call this sort of the brain gym, where you go to neuropsychologists who do rehab and can really help individuals get those skills. Let's remember where your appointment was, or let's take these Post-it notes and have these compensatory techniques that we can use to help you remember things. Lots of dementia-friendly organizations, which I'll talk about soon at the very end, and case management. If you can imagine, in the aging population, there are so many different doctor's appointments and so many different lab tests that you have to go, and this has to be done, and then you have to go to rehab. So having a case manager to manage all these things really does help promote wellness. There are specialized physicians, so geriatric psychiatrists, and the Memory and Alzheimer's Treatment Center at Bayview really is an example of this. So under one roof, we have geriatric psychiatrists, geriatricians, and neurologists, all providing care for the patients with dementia, psychologists who help with this sort of cognitive training, nurses who do a lot of education and support for the families, and then occupational therapists who help those individuals that have dementia work on executive function again. How do we balance that checkbook? How do we, figure out how to not necessarily manage a textbook with dementia, but like how do we go back to putting on our pants properly or tying our shoes, et cetera. And then comprehensive family education and support. And then one of the big things is having access to cutting edge medications like I just talked about with Leqembi and other clinical trials. So finally, with this is a summary of dementia. So Alzheimer's, the take-homes to understand about dementia is Alzheimer's is the most common. The biological process precedes the clinical syndrome. We're really moving in the field of being able to diagnose based on blood-based biomarkers or even neuroimaging and cerebrospinal fluid and making an accurate diagnosis. And a lot of the treatment is going to revolve around those 4 pillars of care: cognitive management, behavioral management, patient support, and management of medical illness. Now we're going to move to delirium, which is the second most common neurocognitive disorder, very different than dementia. So remember, dementia is a gradual process, it's irreversible, and it's happening over time. Delirium happens very abruptly, quickly, and it's oftentimes, if treated properly, can resolve. So delirium comes from the Latin delirare, which means to go off of the furrow. So it's sort of going off the beaten path. And it's a really acute, quick change in a mental status of a person. So their awareness, their cognition, and mostly their attention gets impaired. The difference between someone who's delirious and having dementia is that in delirium, it's a sense of being awake and being alert that gets impaired. A person with dementia may not know what day it is or what month it is or where they are, but they're always going to be alert and they're always going to be awake. Someone who's delirious may not always have that, and that's going to fluctuate across the course of time. And the other key piece is that delirium often originates outside the brain. So the causes of what causes delirium is coming from outside what's happening in the brain. It's typically what's happening to the body. So this is someone who may have a urinary tract infection, for example, and have an acute medical illness that's causing them, or any kind of infection that's causing them to be confused. Or they're intoxicated on opiates and they're very, very disoriented, or withdrawing from alcohol. Trauma and surgery is another reason that people can get delirious. So they've gone into the OR, they just had a really, extensive orthopedic surgery done, and now they're delirious after that. So the key thing with delirium is it's really coming from outside the brain, coming from the body, and causing an acute change in awakefulness and alertness. It usually happens in about 23% of those who are hospitalized, and when I cover on the weekends at Suburban, I oftentimes am consulted because a person is delirious, and we have to manage that aspect of their delirium psychiatrically. It's about more than 20% in those undergoing major surgery, and mostly those who are in for those who are in the ICU, about 50 to 70% of people who are mechanically intubated or ventilated are at high risk of having a delirium. And it's also very common in those who have stroke. Again, it's an acute, quick, fast onset thing that's going on, so a stroke that happens acutely and quickly can predispose people to a delirium. We also see this in palliative care settings. Why? Because in palliative care, end-of-life care, we're seeing people who have a lot of pain medications that can make them sort of altered and confused. This is a picture here of a sign of someone who's in delirium tremens, which is a very classic picture that has been sort of taught across medical education to help students understand when someone's withdrawing from alcohol, what that looks like. But you can clearly see that there's a person here whose attention is off. There's a fluctuation in sensorium. And as we've seen we've been doing a lot of work in the world of CL psychiatry and trying to understand the biology behind delirium. And what we're noticing is that it's truly an abnormality in their sleep-wake cycle. They have day-night reversal, and they don't know when it's day, when it's night, and that level of confusion is really what causes a lot of the fluctuations in their alertness and their wakefulness. They also have a lot of emotional lability, and as psychiatrists, the reasons that we get called is for this second to last bullet, which is the psychiatric manifestations. People are believing that individuals are believing that people are coming into their room and harming them. Oftentimes they'll talk about hearing things, mostly seeing things, like little animals in the room or little people in the room that aren't really there. And agitation, they're climbing out of bed, they're pulling out their IVs, they're like yelling at nurses, trying to punch them. So this is one of those situations where it can be very serious, and it's an acute onset of change that people see, and it can be very scary for family members, that this was not, my mother like 2 days ago, now suddenly she doesn't know who I am, and she doesn't know where she is, and she's hearing voices that aren't really there. So it can be very scary for family members to see this, but the good news is that it's very quickly resolving once the underlying condition is resolved. And then we see other motor and behavioral disturbances that can accompany delirium. For those of you who are docs in the room and who are hospitalists or internists, the most important thing to know here is the management is not medications. The most important thing is to get people moving. So when they're in the hospital, getting them up, having PT, walk them outside the room, making sure they're reminded that it's daytime right now, we keep the room bright. It's nighttime right now, we keep the room dark. Really trying to minimize restraint use. A lot of times with nursing, it's difficult because you see someone pulling out their IVs and they want to put patients in restraints, but in fact, restraints can worsen delirium. So it should be a very short-lived sort of getting people safe through the day or safe through the shift type of thing, or a couple hours, but really be very mindful that we release those restraints. And continuing to provide, if you have family members that you're visiting in the hospital who are delirious, bring them things from home that remind them of, their normal life at home. Bringing calendars saying today is April 18th, it's Saturday, it's 2026, we're at Suburban Hospital, etc. So that really, facilitates faster recovery for these individuals. We don't want to jump to medications, absolutely not, but when we have to, we have to. And the only times we're going to do that is when all of the things have failed. So the verbal and nonverbal de-escalation strategies have been ineffective. We've treated the UTI or we've treated that infection, but they're still very confused. The disturbance that this person is having of seeing this really scary figure in the room is causing distress to them, or that the disturbances are presenting a physical harm. They're trying to elope, they're trying to pull out the IVs. So we really want to be very conservative and not manage with medications unless we absolutely have to. This is just a slide that shows sort of all of the factors that contribute to the risks of delirium, the top being sort of what the person is walking into the delirium with. So what are sort of their demographic factors that are going to contribute to them having delirium. Usually those with advanced age, those with dementia are at higher risk, those have had delirium before, alcohol use, a prior history of psychiatric illness. These are all predisposing factors. When they come to by the time they come to the emergency department and they get admitted to medicine, there are other things that predispose them to delirium as well. So how ill are they? Do they have underlying medical comorbidities, kidney problems, liver problems, seizure disorders? And then when they get discharged from the hospital, some of the things that we worry about is how mobile are they? Are they on pain medications? Are they on other polypharmacy or multiple medications that's making them more confused? So it's a multifactorial thing, and it's something that needs to be really addressed quickly so we can get them better quicker. So in summary, with delirium, it's quick, it's fast, it's abrupt in onset. It's really a fluctuation of wakefulness and alertness. And it really can resolve once you have the environmental interventions that are put in first line and treating the underlying medical condition. You really want to avoid psychotropics unless they're really imminently dangerous, and getting them moving up and out there and getting their mobility optimized is going to be really important. And then finally, really orienting people is going to be the key thing. I'll finally end with mood disorders, which is the other third important condition that I want people to walk away from getting a better sense of. And within mood disorders, it's late life depression. In our geriatric psychiatry clinic at Community Psychiatry at Bayview, majority of the folks that come in are coming in to see us for late life depression. Our clinic is set up where we have psychiatrists seeing the patient in tangent with the therapists that work with the patient. So these are typically individuals who don't have a neurocognitive disorder, but they have some kind of a mood disorder in late life that's really impacting their ability to function. So major depression in the elderly is really important. And what makes it different than any other age group is that there is this co-occurrence with so many other things. The first is those physical disorders that I talked about before that lend itself to frailty, loss of eyesight, loss of orthopedic movement, loss of hearing, et cetera. Mild cognitive impairment, as I mentioned, people can get very demoralized when they realize that they're not able to remember the things that they were going to. That's going to then lead them to have a sadder mood and become more depressed and not sleep as well and not eat as much. The social determinants of health that I mentioned, number one factor usually being social isolation, not having anyone in their immediate orbit to say, hey, let's talk, let's meet up for lunch. That social connectedness is really a huge reason that these individuals can have these problems. Exposure to polypharmacy, sort of having experiences where they're having multiple doctors give them multiple medications which can interact with each other and then just give them an overall sense of not feeling well, and also impacting mood states. And this group of individuals is the highest risk for suicide. This is number across the board. I mean, the older you get, the risk of suicide continues to increase. About 6.7% to 7.5% of older adults have late life depression, and it's the highest amongst those who are hospitalized or are in long-term care facilities. So that's really important to think about places. And so when we're putting our family members in hospitals or we're putting them in nursing facilities, realize that social connectedness piece is now going away. I mean, unless it's a facility that really prioritizes that and values that. But the risk is increased when they're in these particular environments. Women experience a higher risk, about 1.7 times the risk compared to men, and it's really a higher risk in marginalized groups that we typically see, especially those that don't have access to health care. And the lifetime suicide risk is 25 times greater in older adults. So again, this is not something you want to take lightly. You really want to catch late life depression early on. Really early intervention is important, which means screening is important. Most of the times now in primary care, we are seeing physicians do the PHQ-2 or do some kind of a screening tool to say this person has depression, let's catch this and let's intervene early. When there is no cognitive impairment, psychotherapy can be very effective to help people kind of process their emotions, process grief, process loss, kind of re-script their narrative to help them get less demoralized about where they are in their life. It's very well established that socialization is the number one thing that is going to be protective. So really social connectedness, being part of clubs, being part of societies, going out, being with friends is going to be really important in the management of late life depression. And antidepressants work very well because it's a biological illness as well, but combining that with psychotherapy has the most efficacy and the most evidence for improvement. So really, in summary, with late life depression, again, highly prevalent in the elderly, intervene early, combining antidepressants and psychotherapy is the best combination, and socialization is really protective. So I've thrown at you sort of three big things: dementia, delirium, and mood disorders, late life depression. So how do we sort of summarize this, and what do we do with this information going forward? Remembering, number one, in neurocognitive disorders, dementia is the most common. Alzheimer's is the most common subtype of dementia. The field is moving rapidly, and particularly with Alzheimer's dementia, mostly in diagnosis. We've got lots of fancy biomarkers and neuroimaging that we can pick up this disorder much more quickly. But we also have fancy medications and interventions like monoclonal antibodies that we're progressing towards to help individuals. When it comes to delirium, it's a quick, fast onset thing that should not be missed in the medically ill, and it is correctable, and it is treatable, and it is reversible. Late life depression, again, is also something that's very treatable, but it needs to be caught early. Look at the signs of social isolation. Look at the signs of demoralization. Look at how frailty contributes to the feelings of being sad and depressed. Look at how medical conditions are contributing to this. And if you're going to treat late life depression, take your loved one, take your patient, take whoever to a geriatric psychiatrist who will be able to then provide both interventions, which have been known to be effective: psychiatric medications, psychotropic medications, and psychotherapy with the psychotherapist. These are some resources for geriatric mental health that have been very helpful for family members and also for practitioners out in the community. The 36-hour days, I can't recommend this book enough. It's a very helpful tool for dementia care and a practical guide. And there's some other resources here. I also want to point out that the Alzheimer's Association has a lot of really good resources, advocacy groups, and things like that if you have loved ones or patients who are suffering from some kind of a dementia. And I'm going to land on this last slide today. So I'm standing up here today talking about aging, and it happens to be a day that I am a year forward in my year progressing towards that era. So today is my birthday, and as I think about, thank you, and I'm just happy to be able to talk about this topic because I'm hopeful for the future. There are so many advances that we're making in this particular area, and I think that moving our society forward and seeing what is to come with all of the science that we have, all of the social resources that we have, and all the advocacy that we have, I do have hope that mental disorders, psychiatric conditions in the aging population is really headed in a positive direction. And with that, I thank you.
Thank you, Dr. Roy, for a very informative presentation. My questions are related to the how much of the diagnostic biomarkers and how many of the more recent medical treatments are covered by Medicare. For instance, the more recent blood and CSF fluid biomarkers that you mentioned, also the MRI, FDG, PET scans, and the therapeutic agents that you had described, the cholinesterase inhibitors, nimantadine, monoclonal antibodies, lecanemab, and donanemab. How much of these are covered by Medicare?
That is such a fantastic and very practical question because we get that all the time. So the FTG PET for the tau has now been able to be covered, to my understanding, by Medicare. Because the amyloid PET is still a research diagnostic tool, and if there's anyone that has more information on this, please feel free to pipe up. To my understanding, it's not yet because it's only for research purposes now. So the tau PET scan is, the amyloid one, to me, my understanding is not. Typically, I don't have a problem getting cholinesterase inhibitors like donepezil, et cetera, covered for patients, or memantine, which is not a cholinesterase inhibitor, it's another class of agents. Typically, those are no problem, especially if you prescribe the generic. Lecanemab is currently right now in its very early stages. So I think Bayview is doing the infusions, but it's happening still under surveillance, and it's not being covered, to my knowledge, by insurance yet. Yes, so that third picture that I showed of Lewy body dementia, so it's sort of in that category of dementia. So Parkinson's dementia is or Parkinson's disease is sort of this loss of what we call dopamine that is important to regulate movement and to regulate basically planning and executive function and those kinds of things. So when we start to see, and I actually have a very large chunk of patients in my neuropsychiatry clinic who have Parkinson's disease and are now sort of on the cusp of developing the dementia. So what we usually see with Parkinson's dementia is not so much the changes in memory and sort of the amnestic things I was talking about before, but it's usually problems in executive function. So you see their issues of planning tasks, getting up in the morning, doing things sort of to get their day going, planning, organizing, and those kinds of things. The other thing is that there is a huge component of what we call apathy, which is someone that doesn't care about much, but they don't care that they don't care. So they're not even aware that they're just kind of amotivated and that they don't care. So that's what we typically see with Parkinson's dementia, and it is along the same lines of the Lewy body percentages. So like 10 to 20% of individuals who have the Parkinson's disorder will develop that dementia, unfortunately. Yeah, thank you.
Thank you so much for this wonderful summary on this information. It's so important, and happy birthday.
Thank you.
I do have a question in terms of thinking about epigenetics, and could you speak to people wanting to slow down the progression or even prevent as much as they possibly can with regard to diseases and disorders associated with chronic inflammation, and what role inflammation plays on some of these issues with regard to dementia?
It's a great point. I think so. Inflammation is such a broad category because there's so many sort of, again, I hate to use the word biomarkers, but there's so many biological elements that become inflamed in the body. And so there are certain targets that people can use. If you think just about monoclonal antibodies in and of themselves of what they're doing, they're actually attacking the body itself and decreasing the plaques. So I think inflammation plays a large role in just overall health. And we see that a lot of the preventative measures that people are using, for example, the Mediterranean diet or increases in exercise, really have shown to decrease sort of global levels of interleukins and cytokines, which are typically pro-inflammatory agents, over time. And again, there's not a lot of evidence behind that, but a lot of sort of behavioral interventions have been shown. I don't think right now we have anything specifically targeting inflammation or inflammatory markers in this space right now, but at least monoclonal antibodies are attacking the plaques in the Alzheimer's brain. I don't know if that answers your question.
Last question. My mom lived a very, very healthy lifestyle, and yet she died from Alzheimer's disease. She ate healthy, she exercised, she had social connections throughout her life. Is there anything that can be done to prevent these tau and amyloid from growing in the brain?
Yeah, it's a great point. One thing people are really doing now is a lot of the genetic testing. So the ApoE allele is one that's been noted to kind of be associated with AD. The Mediterranean diet has been pretty well established. It sounds like she had a lot of that, and the exercise and things like that. One thing is, if we diagnose early, the question then becomes, well, if you know you're going to develop this disorder, do you start medications in that preclinical stage, or do you start medications early on? But I don't know that much is being done right now to help kind of when someone's already doing the environmental or the behavioral changes, what can be done earlier.
Hi, Dr. Roy. Thank you so much for the presentation. And happy birthday.
Thank you.
I'm wondering, I'm hearing a lot about GLP-1s and the prevention of dementia. I'm just wondering if you could talk about the research on that and where it's going in the field.
I got nothing. I don't know much at all. It's a very early stage. Now, what we do know is that there is a profile. It's a great question, by the way. I love it. And there's a group at Baby that's looking into this, actually. But there is a syndrome of apathy that people do see with GLPs. So what thing we do want to be mindful of, if you have people that are older adults that are on GLPs and they develop apathy, we also know that apathy is a prodrome to dementia, so making sure that we don't really, confound those. But I guess, is your question specifically for whether it's...
I'm hearing it in the preventative, using it as a preventative measure of people who are showing signs. I don't know. I'm hearing this very randomly out there in the, medical community.
Yeah, it's very underdeveloped. We do know it affects dopamine in some way. So if anything, the Parkinson's patients and those folks that have more of a dopaminergic problem may be a target, but it's very early.
Thank you.
I would like to add just one more thing that we're seeing. I think sometimes we get overly optimistic about hopes of where things are going, and then we don't necessarily see, the full gamut of things. And one thing we are seeing in the hospital is we actually are seeing a lot of older individuals coming in on GLP-1s who actually are malnourished because they are not getting enough vitamins and they're not able to get enough food to ingest to maintain their vitamins, and that's actually causing cognitive impairment because they're malnourished. So we are seeing that, so I just thought I'd mention that. Thank you, Dr. Roy.
I should get off the stage.
Happy birthday.
Thank you.
Thank you. This is Dr. Armand Taghizada. So he, as on brand with how I introduced Dr. Roy, I'll certainly give some of his stats up front. So he is a Hopkins-trained psychiatrist. In addition to that, he has actually been voted Baltimore's top doctors 10 years in a row, and is in private practice with child and adolescent psychiatrists there, where they do individual therapy, group therapy, family therapy. He's not the only one there. There are other people helping him with that, but he also is the founder of something called the Mindset Training Institute, because not only is he a child and adolescent psychiatrist, but he's a sports psychiatrist, and he offers mindset training, kind of mental training for elite athletes and coaches. In addition, he has a slew of followers for his TED Talk, and a lot of people follow him on the Mindset Experience. I personally have known Dr. Taghizada for 22 years. We actually did residency together. And what that looks like for me is I feel like he was my cheerleader. We made fun of each other. We kept each other going. But if any of you have watched the series The Pit, I don't know if anyone's watched it at all, but basically a lot of the residents in The Pit lose their mind at some point. They're just they don't know if they're going to make it. They don't know they're cut out for this, and that's real. And so at various times when I just really wasn't sure if I should be a doctor or if I should deliver pizzas, Armand was there, and he was like my constant sort of, okay, we're doing this. And I hope he talks about this in his talk. I'm not sure if he will, and at that time, I don't know that you were saying this, but it really was about, hey, look, you're going to be uncomfortable. Things are going to be uncomfortable. And that's okay. That doesn't mean there's anything wrong. Doesn't mean you're doing the wrong thing. But life is uncomfortable, and let's just go. Let's do it. Let's do it together. Get comfortable being uncomfortable, and let's go. And so I appreciate him, and that we've kept in touch over the years, albeit sporadic. I've been actually trying to get him to do this for 3 years, so he's overdue, but I'm really excited to hear what he has to say. So with that, I give you Dr. Taghizada.
I appreciate it. I hope everybody can hear me okay. I hope my sound is okay. First of all, thank you all for coming. I really do appreciate this opportunity, and it's true, it's been 3 years coming. But like a lot of things, right? It takes time, and here we are. Judging from the earlier talk and from the questions, it's really, really evident that there's a lot of educated people in this room. And typically, when there's a lot of educated people, that means that they've worked really hard to get letters added to the end of their name, right? PhD, MD, JD, LCSW. For me, I've worked really hard to get letters taken away from my name. So I actually go by Dr. T. I am a board-certified child, adolescent, and adult psychiatrist. I'm a board-certified sports and performance psychiatrist. I do have a podcast called The Mindset Experience, and I have a TED Talk called Control the Controllables that has over 1 million views. I'm going to talk a little bit about it, but to Dr. Bowen's point, this has been something that has always been a part of who I was and sort of evolved, and I ultimately had this opportunity to take my experiences and my knowledge and to tie it all together. So let me tell you a little bit about me and why I do what I do. So first and foremost, I was an athlete. I was a former NCAA Division I wrestler. It was a big part of who I was. It still is a big part of who I am. I went to medical school at the University of Maryland. I did my residency at Johns Hopkins. I was the chief resident in 2008, 2009. I'm involved in professional organizations. I'm a faculty member at the Johns Hopkins in the Division of Child and Adolescent Psychiatry. I'm a consultant at Gilman School, the psychiatric consultant at Gilman School, which is a private school in the Baltimore area. I work with the NFL Alumni Association. I'm the medical director at The Hidden Opponent. I'm also in the advisory board of IS Nation, which is another platform. And again, I have my TED Talk. While I'm incredibly proud of all of those things, the thing that I'm the most proud of and the thing that I think sets me apart the most in the work that I do is that I still compete like an athlete, right? Earlier you said to me, it looks like you've been at the gym, right? To me, fitness is such an important part of who I am and what I do. And the reason is not just what we all know in terms of the physical exercise. You know, for me, I work with a lot of young people. And when I say young, I mean anybody younger than me, right? Which is progressively getting more and more, right? But when I'm looking at them and they're talking about challenges that they're going through and things that are hard and things that are challenging, right? Right, like the wisdom that we have as we get older is certainly valuable, but for young people, that's not their experience, right? What they want to know is, do you truly understand what I'm going through? How do you know what I'm going through? And so for me to be able to authentically put myself in difficult situations, right, as Dr. Bone said, actively choose to be uncomfortable, right? Those are things that allow me to connect with my patients and with my audiences in a way, right, that is very different, right? So many of us tell young people, you need to do this, you need to do this. And what they're looking at is saying, are you doing the same thing, right? So this picture here is from an event that I've done the last 2 years, and I'm doing it again. It's called 29029. Now, I don't know if anybody in this room is familiar with those numbers, but 29029 is the elevation of Mount Everest. Mount Everest is the tallest mountain in the world. Now, let me be clear. I did not climb Mount Everest, right? I grew up in the Maryland area, and my sport was wrestling, which is a winter sport. So while my fancy friends from Gilman School were out on their ski trips, I was indoors training. But what they do is they rent out these mountains in North America. And what you do is you climb up the mountain or hike up the mountain, and then you take the gondola down. And you climb up the mountain, and you take the gondola down. Most people do it the other way. And you continue to go until you've reached the cumulative elevation of Mount Everest, 29029. It's a 36-hour event. You have to figure out, are you going to sleep? How much time are you going to sleep? What are you going to eat? How are you going to do it, right? It's a very unique, different experience that I was not used to. But it gave me an opportunity to put myself in a really challenging situation. And so the first one I did was 2 summers ago at Jackson Hole in Wyoming, if anybody's ever skied Jackson Hole, right? Last year I did Whistler, right? And this year I'm going to Mount Tremblant in Montreal, right? And again, these are just things that I do partly to put myself in a situation where I can actually actively train on myself the things that I train with my patients. So why does this matter, right? Like athletics, youth athletics, it's a consistently growing field. It's becoming more understood, but actually largely misunderstood, right? But it's a powerful environment for growth, only when mental health is intentionally protected. So what I'm gonna talk about is things that we can control as clinicians, parents, and systems to prioritize mental well-being, while we can also support healthy athletic development. Today, I want to make sure that we recognize the trends and risks associated with competitive sports. We identify the challenges with increasing intensity, and we apply what I call the 3 controllables to optimize psychological and physical performance. We know that physical activity is important, right? We heard it earlier, right? We know that the benefits of sports can be extensive, right? There's, again, the physical activity component, but social interactions, a sense of accomplishment. For young people, belonging to a community and an organization is so integral to their psychological health. There are financial opportunities, but it is rare, right? But when you look at the physical activity, the social interactions, the sense of accomplishments, the sense of belonging, right? All of those things do translate as a template for success in life, right? And I want to share a story. As I mentioned, I was a collegiate wrestler. Really, my dream growing up was not to be a physician, it was to be a teacher and a coach. And I was a teacher and a coach, right? But my parents had other plans for me, right? They motivated me, encouraged me, slightly forced me to go into a higher level of education. And ultimately, I did become a doctor. But my goal was still to be a teacher and a coach. And why I say this is because when I prepared for my interview in medical school, like anything else I had done in my life, I prepared. Right? I trained, I practiced. What are the questions they're gonna ask me? What are things I need to know about, right? And I was very, very diligent in my preparation. And so I go to my interview in medical school. And for anybody that knows about medical school interviews, typically they last an hour, and there's multiple of them. So I was prepared. I got in, and my medical school interview lasted 15 minutes. And in those 15 minutes, the gentleman that was interviewing me wanted to talk about wrestling. Right? And he talked about confidence, and he talked about discipline, And he talked about humility. And he talked about grit. And he talked about resilience. And as he's talking about these things, I'm wondering, why are you talking about these things? Like, these are just things that people have. Because I thought they were a natural part of our development. And so at the end of 15 minutes, he said, I'm recommending you for medical school. And I stopped and I thanked him. I said, but I'm not sure. Can you tell me why? And he went on, confidence, discipline, humility. And I'm like, here we go again. And he said, look, the world needs more wrestlers. The field of medicine needs more wrestlers. That's why I'm recommending you to medical school. Right now, I want to preface, there's somebody in the audience that knows my parents. My parents were not big fans of the sport. And so I called my mother and I said, Mom, I think I got into medical school. And she said, yeah? And I said, because of wrestling. And she said, you're kidding me. I said, I'm not. This is what they said. And so sport, for me, it was wrestling, but sport does provide so many opportunities for us to grow and develop our sense of self and who we are that directly does translate over to success in life. All right, recently I was at another lecture, and there was a woman CEO, and she was talking about that in C class, right, in organizations, when there's a female in a C class position, 94% of them played a collegiate sport. 94% of them played a collegiate sport, right? So again, we're not all going to be college athletes, right? But we all have the opportunity to grow and develop. And young people, for sure, have an opportunity to use this as a classroom to develop so many skills that can translate to success in life. Here are the trends, though, right? Everything has cost more money. Things are getting competitive a lot sooner. Kids are specializing a lot sooner, which I'll talk about. Training is becoming year-round, right? If you play soccer now, you don't just play soccer in the fall. You play soccer in the fall. There's an indoor season in the winter sometimes. There's a spring season. Tryouts for the fall happen early in the spring. Now, if you're playing two sports like lacrosse and soccer, now you've got two practices, two sets of tryouts. You're not necessarily traveling to the local park or even the town next door, right? Now, every weekend, you're going to different places, oftentimes needing to take extensive car rides, plane rides, right? It takes a lot of time. And the attitude is more to win at all costs, right? Just yesterday, I had an athlete in my office who plays for a competitive team, and their team is known to win. But their coach is also very, very well known to yell, scream, demean, right? Yet parents send their kids there. And the parents even said, we pay for this. We're paying for this, but we have a problem with it. But the team is winning. They're nationally ranked, right? And it becomes this dilemma, right? Because if that's going to help my kid be the best that they can be, whatever that word means, right? Do I continue to put them in this toxic environment, right? Or do we look at something that's a little bit less competitive? But then their friends, their teammates are in that environment, right? So it becomes a really, really challenging dilemma. These are some of the risks. Oftentimes kids define their success by how they did in school or if they got into college for athletics. They're worried about disappointing, right? Every child is worried about disappointing their friends, their family, their coaches, right? And even themselves. We see kids getting injured a lot sooner, and these are serious injuries. There's more conflict between parents, kids, parents and coaches, kids and coaches. And we do see higher rates of anxiety, depression, and burnout, which I'm going to talk a little bit about. I'm seeing earlier and earlier ages where kids are developing substance abuse problems, right? And I'm not just talking about dabbling, I'm talking about consistent use to alleviate stress, to help them sleep, right? We're talking 8th graders, 7th graders even, that are consistently using marijuana to be able to help them sleep. And we see kids actually leaving earlier to go to college, right? And this is called a gray shirt in some sports, but we see a lot of seniors, high school seniors, that will graduate early so that they can get a jump and get practicing, right? And again, the problem with this is, yeah, they get an earlier start maybe and they get to develop time with their team, but that second half of senior year, right? That senior year where you're really, you want to spend time with your friends, right? There's so many activities, right? It's an opportunity to finally breathe and appreciate all the hard work and everything you've done in your community, right? You miss out on that. And that's hard to get back, and that's a big part of development. Let's talk about some of the challenges. So I just want to throw out some statistics, right? Significantly less statistics than we heard in the earlier talk, but some statistics, right? Up to 70% of kids discontinue playing organized sports by the age of 13. right? Think about how many kids get involved in youth, rec, club activities, right? And they're playing multiple activities, right? You go to these complexes and it's swarming with kids, right? It's chaotic, but it's kind of, there's something really special about it, right? By the age of 13, 70%, right? And it's not that they're not talented enough. It's not that they're not capable of playing the sport. It's that they're bored, they're tired, right? They're frustrated, they're burned out, and they're not having fun anymore. Only 3 to 12% of high school athletes compete at any collegiate level. At any collegiate level. And this is across all, right? And so, again, when kids start playing sports, sometimes this sort of attitude from the coaches is, we're going to help your kid play in college. And sometimes from the parents, it's like, we're going to get a scholarship, we're going to go Division I. It's rare, right? Now, I don't say this to discourage people from achieving that. I don't think any goal is too high if you're willing to work for it, but I do think that there's a way to approach it in a healthier, strategic way that's going to make it more likely that you achieve that, and along the way, you're going to be set up to be successful in whatever you do and make that choice versus have it be an obligation. You know, there's sort of this idea of going professional. Only 2% of NCAA athletes go pro. Of NCAA athletes, right? So it gets less and less. So ultimately, when you look at the percentages, 0.03 to 0.5%, that's less than 1% of any high school athlete actually plays professional sports. And again, the idea is not to discourage our athletes from achieving high, but it's to help them understand that if you want something so rare, so unique, it's not just what you do on the athletic field. We have to build up your mind. We have to build up your sense of self, your confidence, all of the things that make you a resilient human being so that you're more likely to achieve that. And if you don't, guess what? You're going to go pro in something else. Injuries are very common, but I want to point this out. 50% of injuries are related to overuse. It's not something rare or traumatic that often happens. It's that we're fatiguing our muscles because we're training so hard that we do something that we've done 1,000 times and our muscles give out because they can't just hold, right? So it's also important to understand what's happening and why it's happening. There's this perception that 1 out of 5 U.S. youth experience mental illness. That's the statistic that's stated. The reality is that 5 out of 5 are impacted. Because at some point, it is very possible and likely that person will develop a mental health condition, right? If they don't develop something, somebody in their community, a friend, a teammate, a family member, right? A child, right? These are things that can happen, and they can happen to anybody. We know that ages 10 to 34, suicide is the second leading cause of death. The second leading cause of death. And 90% of suicide victims experience symptoms of mental illness at some point. But a lot of times we don't see it, we don't know, right? And oftentimes with the high-achieving athletes, right, it's not seen. You know, I told you that I was the consultant for Gilman School, and I'm on their health committee, and we recently had a session, and they were talking about, within the private school communities, how we really need to pay attention to the quiet kid that sits by themselves, right? The kid that's not a problem, right? The kid that doesn't speak up. And so I agreed with that, but I said, but you also need to pay attention to the kids that's the captain of the athletic team, the lead in the school play, right? The kid that's getting his pieces of art always in the production, right? Because those kids also are getting praised for their successes. They're getting praised for what they're doing, and they don't oftentimes know who they are. And if they are struggling, they don't want to speak up because they don't want to disappoint everybody that believes in them, everybody that tells them, you're such a great athlete, you're such a great student, you're such a great actor, right? You're such a great artist. That's hard to consistently hear and then feel like, but I don't feel great. And if everybody else thinks I'm great, but I don't feel great, what's wrong with me? Right? And so we have to be able to look and look deeply. And it's not that we shouldn't praise our kids, but we also sort of be looking through a different lens. Mental illness does not discriminate. And oftentimes, elite athletes are more vulnerable to some of these conditions. I get asked a lot, what do they have to worry about? They go to a great school. They play sports. They're successful. Why are they stressed? Why are they depressed? Right? These are conditions that affect all of us because they're human beings. That's why. Right? And oftentimes they have more pressure, either externally placed or internally placed. this concept of mental toughness comes up a lot, right? And what you'll learn through this conversation is that I'm very big on language. I'm big on language in terms of what we say and how we say it. And so I have a lot of coaches say, well, kids need to be mentally tougher. I'm like, really? Tell me, what does that mean? And they're like, they need to be tougher. I go, sure, tell me what that means. They can't tell me what it means, right? And again, we have a sense of what it is, but like, the harder you play, the more likely you are to develop injuries and overuse injuries, and this can cause you to leave your career earlier, right? While you're socializing with your teammates and you develop a sense of community within your team, you're often isolated from other kids that don't participate, right? Sometimes those are kids in school with you, and sometimes those are your own family members. And the relationship of the family also oftentimes revolves around the sport, right? And there's a lot of conversations about the sport. Now, part of it is planning. We have to go here this weekend. We have to do this. We have to do this. But part of it is, let me tell you about how you played today, or blah, 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 right? Or let's talk about this game coming up this week. Who do we have? What do we need to worry about? Like, there's a lot of conversations that are specifically around the sport. And I can't tell you how many times I have a child or an athlete tell me, I don't want another coach in my house. I just need my mom. I don't want another coach. I just want a dad. But they don't know how to say it. Why? Because they're afraid of disappointing. And the other interesting thing is, right, like while athletics develop so much independence, oftentimes these young people are reliant on adults to plan their schedule because there's transportation, right? They pack their bag for them oftentimes, right? They want to make sure they have everything they need because there isn't a lot of time. But in that, these young people don't learn how to plan for themselves. They learn how to think ahead. And they rely so much on other people. Autonomy, executive functioning, if you will, right? Discipline, like these are all part of the psychological stages of development. It's an important part of growth. If we want our kids to be mentally tougher, we need to allow them to think for themselves. We need to allow them to plan. If they don't show up with their shoes, that's okay. They're going to learn. They're going to learn. And oftentimes, there's another set of shoes there waiting for them, right? But oftentimes, we feel like we need to show up, we need to give them this and give them that because we don't want to let them down. In actuality, though, they may not develop the sense of independence that they can have. And oftentimes, too, they're not exposed to other sports or other demographics, right, that they would otherwise get experience from or be able to enjoy, right? And people grow at different rates, right? A lot of people, the height that they were when they were 12 or 13 is not the height that they're going to be when they're 18 or 19. For me, it's always been the same height. But for a lot of other people, right, they grow and they develop. And so, somebody that's the tallest kid on the basketball team at age 12 might not be, right, when they're 13, 14, or 15. So to say, wow, you're tall, you're going to play basketball, or wow, you're really short in style, you're going to be a gymnast or wrestler, may not necessarily fit their needs. So I think it's important to look at the overall trajectory and expose them to a lot of different things. Earlier, Dr. Roy used the word normal a couple times, right, in your talk. And a lot of people say to me, is this normal? Is this not normal? Is it just normal teen? There are a lot of words that I use intentionally, and there are a lot of words that I've intentionally removed from my vocabulary. Normal is one of those words. Because I think, if anything, the last several years of our lives have told us is that nothing is normal. In fact, normal is abnormal. So I try to use the words typical or atypical. It is typical for a young person, including an athlete, to experience anxiety, doubt, fear, discouragement, demoralization, frustration, anger. Grief is a normal response for a young person when they don't make the team, when they get cut, when they get injured, right? Something that is so important to you, something that means so much to you, when it's taken away, regardless of the circumstance, can evoke a lot of emotional responses. A lot of kids who have injuries go through a grief response that they're not prepared for, and everybody focuses on the physical aspects of the recovery and the process, but not the emotional or psychological. These are typical. When you start to notice that your athlete or your young person is just persistently sad, or there's an unexplained change in their energy, appetite, sleep. And again, I recognize that young people have atypical sleep, energy, and appetites. But when it's a change from their baseline, when they're really critical of themselves more so, they're not having fun, they're avoiding other activities that they would have enjoyed before. They're getting sick a lot, they're getting injured a lot, right? These are things that we need to pay attention to instead of, hey, it's just a big game, like you'll be okay after the game, or I know it's junior year, it's a stressful year, but you'll get through it. That may be part of it, but there might be more. And I think it's important to look and ask questions, and oftentimes even to listen. burnout or overtraining syndrome is a very real condition, right? Oftentimes we use it kind of in a cavalier way and we say, oh, I'm burned out or I'm burning out, right? But again, it's important to understand what's sort of a symptom and what's a syndrome, right? Burnout can be a syndrome. And oftentimes, again, when you see changes in energy levels, sleep levels, appetite levels, changes in mood lability. I understand that young people can be angry or irritable. To be fair, older people can be angry and irritable. People can be angry and irritable. But when you see changes, right, in that, right, when you notice that they're more cynical, they're detached, they're withdrawn, even from people that they tend to gravitate towards, right, they're withdrawn from, these are important things to pay attention to. When you notice that they're not playing better, in fact, despite the fact that they keep going to practice and they seem to be putting in the work, they're getting worse, right? Or they're more detached. That doesn't necessarily mean they need to train harder. It might mean that something else is happening. The reason this is important is because this interferes with psychological development. And it's hard to recover or respond. It's not just, let's take a weekend off. We're going to avoid this showcase, and then we'll be back to good, right? Like, it's hard to catch up. It's also hard to catch up on sleep, by the way, right? Like, these are things that need to be consistently monitored and regulated to avoid being in that 70% that discontinues by age 13, right? And by the way, this can happen in athletes, but it can also happen in family members, right? It can also happen in family members, right? Why is it important to diversify? And I'm not talking about money here, I'm talking about sports, right? Diversification allows the development of different physical and mental skills across different sports, right? It's effectively cross-training. When you still look statistically at NCAA athletes, now when I told you 3 to 12% across all divisions, when you look at Division I, which is what sort of a lot of people gravitate towards, it's like 1 to 3%. 1 to 3% of high school athletes play Division I sports. When you still look at NCAA athletes, they're more likely to play multiple sports in high school. And their first organized sport is likely different than the one they did. Right? My first organized sport, I believe, was t-ball or baseball, right? Very different. Early diversification and later specialization actually leads more to elite status and longer athletic careers. You get to be exposed to different people, different coaches, different demographics, right? How often do we tell people, right, that it's important to learn different ways of thinking, different people, right? We talk about diversity so much. Well, diversity isn't necessarily being in a school where you have a diverse group of people. It's also being in different sports where you're being exposed to different people, different coaches, right? Some of my best friends that I met through the sport of wrestling are people that I never would have met if it wasn't for that sport. People that I never, just different areas of living, different ways of growing up, different socioeconomic levels, right? Some of my best friends are people that I would stand next to and you'd say, I have no idea how you're friends with this person. Why? Because they're a good person and I love them for who they are, right? And I wouldn't have met some of these people if it wasn't for that sport. Again, diversification also allows the ability to keep pursuing and excelling even though our bodies are changing, our minds are changing, our interests are changing. These are two athletes that are relatively well known. And if you don't know who they are, I'll explain. But the first one is Abby Wambach, US national team, right? Just an incredible athlete and incredible human being. And she talks about playing basketball and how it had a significant impact on the way she played soccer. Because we're in Maryland, right? I always have to throw a Maryland reference up, and I'm a football fan as well. And this is Ray Lewis, for those of you who don't know, Professional Football Hall of Famer. But what a lot of people don't know is that Ray Lewis was a wrestler first. Ray Lewis was actually a Florida State champ. And he started playing football so that he could get in shape for wrestling season. But then what he learned through wrestling helped in terms of his body mechanics, his awareness, and his grit and resilience, and a little bit of that chip that he had through the sport of football. Ray Lewis's father, by the way, was also a state champ. And Ray Lewis had a very strained relationship with his father growing up. And when he went to high school, his father's name was on the banners of all these records for wrestling. And he said, I'm going to take every one of those down. I'm going to take every single one of those down. And he did, right? And again, that sport for him played a role in him also defining who he needed to be independent of his circumstances and who he ultimately was in the sport. So let's talk about the controllables, right? It's interesting, right? My TED Talk is called Control the Controllables. I talk about it a lot. I think I was talking about it even before I knew I was talking about it with Dr. Bowen in residency, right? Because that's exactly the conversations we had. And oftentimes, she wouldn't come to me. I would see a look on her face, right? And I'd sit her down. I'd say, let's go get a cup of coffee. We need to talk. And we would complain and bitch and whine like a lot of residents would, but then we would talk about what can we control? What can we focus on, right? How can we make that experience better, right? And both of us would leave better people, right? And I got just as much out of those conversations as she did, right? But controlling the controllables is an important thing. Now, a lot of people say that. I don't know if anyone's ever heard that. But again, a lot of people say a lot of things, and they don't necessarily know what they mean or use them in appropriate context. But I want to share with you sort of how I approach the 3 controllables and how we can apply them not only to young people in sport, but also to everybody in this room. This is from my TED Talk, which, by the way, was the hardest thing that I've ever done in my entire life, right? And we can get into that another time if anybody has specific questions, but by far the hardest thing that I've ever done in my life. And I almost walked away from it when I was at stage 6 of the interview process. And they said, we want a list of 15 cited references. And I said, really? Like, we're stage 6. I'm talking about my life, my experiences, and now I have to give you peer-reviewed cited references? And I said, I'm not doing it. And my wife looked at me. She said, really? You're going to give up just like that? And I was like, excuse me? And she said, you tell people to be uncomfortable with, get comfortable with being uncomfortable and to control the controllables, and now, when you're in this situation, you're just going to give up? And I said, are you seriously saying this to me right now? She goes, I mean, I'm just saying, if you want to walk away, that's fine. And I said, all right, fine, I'll give him this. So I gave him 25 peer-reviewed articles. To me, the controllables are effort, attitude, and gratitude. Now, what I hear a lot of people say is effort and attitude, but they forget gratitude. And gratitude is incredibly important. We're going to talk about both of these, not just, all 3 of these, not just in the context of what they are, but how they impact our lives and our psychology. How many of us in this room conceptualize effort as a physical, right? Putting in more work, showing up, putting more hours. A lot of us, right? And that's how I used to conceptualize it. In fact, when I was in college and I wrestled, I worked out 4 times a day. Because I thought the harder you worked, the more successful you would be. What I've realized through my experiences is that effort is largely mental. It's how we think about things. It's how we approach things. It's about how intentional we are with what we do. It's not always about working harder. Sometimes it's about working smarter, and sometimes it's about being different in the way we approach work. Some of us might think of that as a break. Some of us might be that we're intentionally recovering. What I do with my athletes is I tell them to focus on 3 areas a day, right? My athletes are students. So I say, make sure that every day you focus on one thing for school. They're athletes. Make sure you focus on one thing for your sport. And they're human beings, most importantly. Make sure you focus on one thing for yourself. Now, if every day you intentionally do one thing for your school, one thing for your sport, and one thing for yourself, then at the minimum, you've done 3 things. And I call those the daily vitamins. Now, if you take 3 daily vitamins a day, by the end of the week, that's 21 things. By the end of the month, that's 90 things. It starts to add. And so if you're having an incredible day and you're highly motivated and you're positive and you're upbeat and you're quote unquote happy, you might say, you know what, I'm going to get ahead of that assignment and I'm going to go do extra research. You know what, I'm going to show up to practice early and work on this skill or that skill. And you know what, like I'm going to go for a walk or I'm going to connect to a friend, right? Or I'm going to read, something there. I'm going to start a project that I wanted to do. But if you're really struggling, you might say, I'm just going to go to school today. You might say, I'm just going to go to practice. You might say, I'm just going to get out of bed. But even being intentional and doing 3 things a day starts to train your mind that you can do things, right? And you can take small steps. And that can reinforce our sense of self, right? That actually facilitates our brain to release different chemicals, one being dopamine. Dopamine helps us with motivation, attention, organization, effort, mood, right? All of these can happen by being very intentional in what we do. I talk a lot about processivity over productivity. So many of us are focused on outcomes, what we want to do versus how we're going to do it. And again, when we talk about doing 3 things, we're focusing on the process. I also want to just take a second to say why I came up with the number 3, right? It's intentional. Everything I do is intentional, right? We learn in chunks of 3 to 5. Human beings learn in chunks of 3 to 5. So think about how you remember your phone number or how you articulate your phone number to somebody else. A phone number is 10 digits long. But what do? We do 3, 3, and 4, right? If anybody has a credit card or a debit card in here, feel free to pull it out. Provided it's not an American Express, the numbers are probably grouped in 4 chunks of 4, right? For those of us that exercise, if we go to the gym, typically we do 3 to 4 sets of each exercise, or 3 to 5 sets of each exercise, and we do 3 to 5 exercises. That's how our brain learns. It's actually called chunking. It's not even that creative of a term. But by focusing on 3 things a day, you're facilitating your brain's learning process. You're stimulating dopamine. That's why it's so important. And again, it's about being intentional. So whether you're telling your athletes or your kids, right, or your young people to focus on school, sport, or themselves, or we as adults focus on something in our profession, something that's personal, and something that we're passionate about, make sure that we're putting our effort into doing our 3 daily vitamins. Attitude's another word that gets used a lot, but it's misunderstood. Attitude is not about having a good attitude or a bad attitude. Attitude has to do with the way we think. Now, the way we think directly influences how we feel and what we do. So this picture here is called the cognitive behavioral triangle, the CBT triangle, which is used a lot in cognitive behavioral therapy, right? But the way we think directly impacts how we feel and what we do. And just to give you context of how we think, on average, we have 60,000 thoughts that go through our head every single day. 60,000 thoughts are going through our head every single day. 80% of them are negative or they're irrational, right? So they're very critical or negative, or they don't make sense. They're not the way we want to think. And 90% of them are repetitive, meaning we've heard them before. So our young athletes, including ourselves, have all these thoughts that are running through their head. The large majority of them are negative and repetitive. And we're telling them, you got to be positive. You need to be more positive. Now, even though we have all these thoughts that go through our head every single day, at any given moment, we can only have one thought at a time. And that thought is going to directly impact how we feel and what we do. So we can choose to think great, and then we're going to feel great and be great. Now, how many in this audience are familiar with the concept or even believe in the concept of an affirmation or an affirmation statement? Right, I see some hands, right? Now, affirmation statements are interesting because oftentimes these are motivational things that we say when we're struggling, when we're down, when something is hard. Why would you wait until you're struggling or something is hard when you likely have a negative thought in your head at that moment to then try to motivate or inspire yourself? Right? We tell everybody it's important to practice. Practice what you're going to do so you're ready for game day. Right? Study for the test so you're ready. Right? Language is the same way. So just to be clear, the idea and the theory of an affirmation statement I totally believe in. I love it. But the application, I disagree with. So I talk a lot about signature statements. Signature statements are different. Right? Think about when you sign or write your name. In what situations do we sign or write our names? Right? Not just when things are difficult, not just when things are hard, but like on a piece of paper, when we're buying a cup of coffee, when we're buying something bigger, right? When we're signing a contract, right? We write or sign our name in multiple different situations, and most of the time it looks similar. And we don't even think about it. We have full confidence that what we're writing is our name. We identify with it. We own it. So again, if we want to think great, we have to come up with something that we're going to identify with and we own. Now, I have a couple, but one thing that I use a lot is the statement, one more. The statement, one more. And originally, it came about, or I came up with it while I was in the gym. Now, for anyone that goes to the gym, whether you do a workout or a workout is given to you, right, if the workout calls for 10 reps, 10 repetitions of that exercise, most of us do 10, right? Most of us that are hardworking and diligent. I know that most people do 10. So I do 10. But then I tell myself one more. And I do one more. And to be clear to everybody in this room, I went to medical school. I'm educated enough to know that 10 plus 1 is 11. But in my mind, I'm not doing 11. I'm doing 10. And then I do one more. And what I'm telling myself is, when you think you're done, you can always go a little further. You can always challenge yourself to go a little further. Just a little bit. But I'm also telling myself, when everybody else stops at 10, you go further, which means you're working harder than everybody else. Now, don't just do it in the gym. When I'm reading a book, after I close a chapter, I say one more and I read one more page. I have 2 boys, a 5-year-old who also had a birthday this week, and a 2.5-year-old. And when I read to my 5-year-old at night, we read a book. And then he looks at me and goes, "Daddy, one more book." And I look him right in the eye, say, "One more." And then he goes, "Daddy, one more teeny tiny book." Now, I know my son is stalling. I know he doesn't want to go to bed. But I look him in the eye and I say, "One more." What I'm telling him is I always have time for you. I will read one more book for you. And what I'm telling myself is whatever you think you have that's more important, like an email, right, or a lecture that you have to prepare for tomorrow morning in Bethesda, this is more important, right? And so I say one more, and I'm training myself to always do a little bit further. So again, even if it's just one more day, one more class, right, motivating our young people that, yes, I know it's hard, and I don't know what it's going to look like. And we don't have to say things like, it'll all be worth it in the end. It's just, can you do one more day? And oftentimes, they can do one more day, right? So really thinking about how we use these terms. I want to talk about this term, because this is a concept that if we're truly, truly being honest, everybody's terrified of, right? Especially our young people. And I want you to think right now as I'm talking about this, about a time in your life where you believe you failed. And I would imagine most of us in this room have had at least one experience where they believe they failed. I really hope so. So think about that experience right now, right? Think about the experience that you think you failed. And when that happened, what were you thinking? What were the thoughts that you had? Now remember, I talked about the way we think directly impacts how we feel. So when you had those thoughts, how were you feeling? And the way we feel directly impacts how we respond or what we do. What did you do? The way we think directly impacts how we feel and what we do. So if we think that we're not good enough, we're letting everybody down, we're going to feel sad, angry, frustrated. We're going to be less motivated. We're going to put in less effort, and ultimately, we're going to do worse. But again, attitude has to do with the way we think, and we get to choose how we think. That is something we can control. So we can take the word fail, F-A-I-L, and we can choose to think about it like everybody else does, or we can reframe the term to stand to first or further attempts in learning. Now think about that phrase, first or further attempts in learning. When you hear that phrase, first or further attempts in learning, what does that phrase mean? Right? There's more opportunities. There's room for growth. When you feel like you can grow or evolve as an athlete or as a person, how are you going to feel? And ultimately, how are you going to respond? The way we think about things has a huge impact on how we respond. And again, with my athletes, I talk a lot about the language and the thoughts that they're having, and not just telling them you can do it, believe in yourself. If you believe it, you can achieve it. But how do you choose to think differently, right? And how do you reframe these experiences? Because the reality is that the most successful people in this world have probably had the most failures, myself included. And again, I also just want to point this out. I'm not particularly a faith-based person, right? But this is the Jesus statue from the dome at Hopkins, right? And there's a sense of enlightenment that comes from knowing that we can grow through our failures. Gratitude is probably the most important controllable and the one that's the most misunderstood and misutilized, right? We talk so much about gratitude and how important it is to be grateful. In fact, we tell our young people that all the time. You need to be more appreciative. You need to be more grateful. You're not grateful enough, right? Why is it so hard to be grateful? Why is it so hard to be positive? We all know that it's important, but how many of us in this room can actually apply it systematically and easily? It's hard. One of the reasons is something called negativity bias, right? We are more prone towards negativity. In fact, in the human brain, negativity is 4 to 7 times more powerful than positivity. 4 to 7 times more powerful than positivity. The toughest opponent athletes are ever going to face is not the person on the other side of the mat or on the field. It's the one in their head. Now, we also tend to talk about things that are negative more. Some of us call it whining, some of us call it blaming, some of us call it complaining. But we talk about it more. And when we talk about things, it adds more power, up to 10 times more power. Right? Think about when you come home, someone's like, how was your day? Ugh, traffic was horrible. Ugh, this coworker was so annoying. Right? We always go towards the negative. Even our athletes. Oh, I can't believe I missed that shot. Oh, what about, I can't believe I didn't take that opportunity, right? That's how we think. And so it's not just about being more positive, it's about understanding the way we think. Now, we also know that when we have fun, we're more likely to be successful. Some of us have gotten it backwards. We think if we win, then we'll have more fun. It's when we have more fun, then we're more likely to win. Enjoyment releases chemicals like dopamine in the brain. Dopamine promotes mood. It promotes attention, motivation, organization, and effort, as I mentioned. This is integral for success. But gratitude is also important, right? When we appreciate our experiences, our brain releases two particular chemicals, one called serotonin. Serotonin also makes us happy, but it also lowers anxiety. And oxytocin. I imagine that a lot of you know what oxytocin is, but oxytocin helps with bonding, attachment, connectivity. When your mood goes up, your anxiety goes down, and you feel more connected to what you're doing, you're more likely to do better. Everything I teach my athletes is things that I do. Everything I'm talking to you all about are things that I do in my life. To me, gratitude is the one that I'm the most proud of, except for climbing that mountain. But I took time during that mountain, every ascent, to make sure that I had gratitude built in, right? That was an intentional part of it. But let me talk a little bit about how I apply gratitude, right? So I call this a culture of appreciation. I call this a culture of appreciation, right? And now let me just take a second to tell you who all these people are. These are our incoming intern class, right? When Ashley and I first met in 2004, there were 8 of us. And these are those 8 people, right? And we went through a lot of tough times, and we weren't always fans of each other, but we grew together, we stuck together, and I appreciate these folks more than they know. And they all look pretty good, actually. Number 1 is look for things to appreciate, right? Like, really look for things to appreciate. The more we look, the more we appreciate. So let's be intentional about it, right? The more you look, so encourage your young people to look for things, right? Whether it's being on their team, who their teammates are, who their friends are, right? The fact that they get to do something they love outside, right? And for you all, look to appreciate the opportunity to watch these young people grow and develop. The opportunity to put your laptop or phone down and just sit on a field in the beautiful sun, right? And be able to just watch that developmental process, right? Like, just really let's look to appreciate, because we also don't know when that time gets taken away. And oftentimes we look back and say, wow, I wish I'd appreciated it more, right? We think about that in our stages of development as we get older. One of the biggest things is we look back and say, wow, I wish I appreciated that more. And we see, in terms of even health and development in older people, is a lot of times based on their level of appreciation and gratitude. So really look for things to appreciate. By the way, the more you look, the more you find. The more appreciation, the more serotonin and oxytocin. Celebrate. We don't celebrate enough. Celebrations are fun. Psychologically, celebrations are fun. When we celebrate a birthday, a graduation, an event, right? Our brains already start to have fun before the event even takes place. Oftentimes, we're having more fun than the actual event really even is, right? So celebrate your kids' effort, their attitude, the fact that they're showing up. Instead of the outcome, focus on the process. And like Ashley said, or Dr. Bone said, not everything is easy. A lot of things are hard. And it's not always going to be positive. And when we want something really bad and we work really hard for something and it doesn't work the way we want it to, that hurts. And forgive my language, but it sucks. It sucks. Now, the large majority of people, when something sucks, what do? They shut down, they withdraw, or they complain. And the situation then sucks more. This is where number 3 comes in. Embrace the suck. Embrace the suck. Now, again, I'm very intentional with language, and this is a phrase that some of you all may have heard before, right? It's a phrase that's used a lot in this sort of gym culture, military culture, but it's used incorrectly. Oftentimes people think this means just go through it, power through it, get through it. That's suck it up. That's not embrace the suck. Embrace has to do with truly accepting something with all your heart, right? Think about the act of embracing is to give a hug, but like a real hug, where you pull something in. When you embrace something or somebody, a community, an idea, a foundation, a cause, you're going into it with all your heart. You're taking something very, very difficult that a lot of people think of as negative, and you're turning it into a positive, right? Psychologically, we can overcome so much when we realize that it's not something we have to get through or just deal with. It's something that we recognize, this is hard, but this is why it's worth it. This is hard, but I can do hard things. I just have to do one more day. I have to look at opportunities to learn, right? Those are ways that we can embrace the suck. So I'm going to leave you with this, right? Everything I say or do are things that I try to incorporate in my life. And the way that I've incorporated gratitude is through my gratitude challenge. And this is different than a lot of people think about gratitude. What I hear of a lot of people do, and this is no disrespect, but a lot of people sort of say, I focus on 3 things or 5 things, or I write down 10 things I'm grateful for, right? And that's phenomenal, but it ends up being the same 3 or 5 things. My family, my health, my happiness, right? And those are things that we're truly grateful for, but it's different. The way that I do it is through a challenge, and it originally started with my wife and I. And what we would do is at the end of the night, she would look at me and she would say, what's your one thing? And I'd have to list one thing that happened that day. One thing that happened that day in my life that I'm grateful for. And then I would say the same thing to her. Now, to be clear to everybody in this room, I absolutely love my wife. I adore my wife. We have 2 beautiful children, right? But I also want to make it clear to everybody in this room that once an athlete, always an athlete. Once a competitor, always a competitor. I want to win the gratitude challenge. I want my thing to be better than her thing. So I wake up and I start looking. This morning I got up at 6 a.m. That's early on a Saturday. But guess what? It was a beautiful day. And as I'm putting my clothes on, I think I get to see one of my best friends, Ashley Bone, who I haven't seen in a long time. I get to come and I get to meet people that I haven't met. I have my windows down on 95. Why? Because the weather is beautiful. And I'm just thinking, and I'm thinking about our experience. I'm thinking about what I'm going to talk about, right? I get here and I see somebody that knows me from when I was a child. And she says, I came here to see you. Right? Like, I'm always looking for things to appreciate, because the more I look, the more I find. I try to celebrate experiences. But almost every day something challenging happens in my life, and some days it's more than others. And if I whine about it or I complain about it, it doesn't help me win my challenge. And I want to win my challenge. So I look to reframe it or grow from it. We can choose what we think about. So my encouraging thought to you all is every day find one thing. Find one thing that you're grateful for. Ask your young people to find one thing that they're grateful for. But young people like to compete. Make it a challenge, right? At the end of the night or at the dinner table, what was your one thing? Here was my one thing, right? Let's turn it into something that actually stimulates us to want to be better. These are my young boys, right? My youngest, this was a couple years ago, he has a onesie that says embrace the suck. My oldest just turned 5, that's him on a wrestling mat. And this is pretty much what exercise sometimes looks like these days, right? Is carrying both of them around. But I really appreciate your time. I appreciate your thoughtfulness. My message is really geared towards athletics and young people, but in reality, we're all athletes in some capacity. And we might not be field athletes or wrestling athletes, but we're life athletes. We're all training to be better at something. So let's take these concepts and let's apply them, and hopefully we can all stay young as long as possible. Thank you.
Hi, Doctor. I thought your presentation was great. I learned a lot, so thank you for that. When you talk about the having fun and then you will win, I have a 12-year-old basketball player, and they seem to lose every close game, and I want him to be addicted to winning. Is that wrong to sort of try to set that stage, like take this seriously at the end, that grit, resilience, or should you just like have as much fun as possible, whoever wins? Is there, because you are a performance psychologist, and it's not just all about kind of staving off mental health. It's like, okay, how do you perform the best to win? Where's that balance between having fun and really teaching what it takes to sort of dial in at the end to win?
Yeah, so it's a great question, but I'm going to answer it with a question. How are you defining winning? Is it by who scores more points at the end of the game, or is it about what you learned and what you could do to get better? Right? If you come away from it and you're like, you know what? That was close, but we could have done this differently. We could have done that differently, right? That's winning, because now you're learning how to get better. And so when you go to practice, it's not just about hanging your head down. It's about, these are the things that I work on. But the other thing you're gaining, right, is your hunger, right? You're saying, hey, how did that feel? We didn't like the way that felt. What could we have done differently, right? Like, yeah, there were some calls that didn't go away. Yeah, that kid shot, whatever, 10 for 13. But what are things that we can do and we can grow from? So to me, it's less about the outcome, right? I don't think, look, at the end of the day, I think when we play sports, a lot of us define it by the outcome. So to me, but if we take that outcome and we say, if you really, really want to win, if you're having more fun, you're going to go that extra effort. You're going to put in more effort. You're going to be more motivated. You're going to be more locked in. Like, that's the formula to be successful. right? That's the formula, because it's going to get hard and you're going to have games that don't go your way. But if you're having fun, you're still willing to show up and dig a little bit deeper. If you're not having fun, how are you supposed to rebound and respond? And so that's the way that I would sort of think about it, is winning is what some people are going to define into the score, but the other thing is, what did we grow, what did we gain, how did we get better, and how we can apply that next time we go out to be able to score more points. And if we come out on top on the score sheet, that's fantastic, but every game, every opportunity is a further attempt in learning.
I consider that good training, because you'll remember your negative experiences more than the positive ones, and you'll correct that as you go through life. Thank you.
Well said, dear.
Well, so it's true that we do, what really happens is we remember our emotional experiences more, right? And negativity has more power than positivity. So part of it is, yes, it is good training. It's important to look at that, but also even asking questions about what did you gain from that? Again, what did you learn from that? What did you do well, right? Because they're not always going to see it, and we're not always going to see it, right? Even think about it at the dinner table. We don't necessarily see when they pass the salt to their sibling. What we do see is when they yell something or say, I don't like this food, right? We always see the negative more, so it takes a lot more work and it's more intentional. But part of it is understanding the power that negativity has, but also understanding what we do is we remember emotional experiences more. So even in our lives, emotional experiences that have been incredibly positive, right? Even if they have a short period of time, we actually remember them more. And negative experiences, even if they have a little bit of time. So our brains actually process experiences not by chronological time, but by the experiences that we have, right? And so part of it is us trying to be intentional about identifying those positive experiences so that we can start to look for those more and more, right? And again, it takes practice. It's not just about saying it or believing it. It's about actively putting it into your intentional training. Thank you. I appreciate it.
I want to again thank the McMahon family for their continued involvement in making this happen. And I'm grateful for everyone who's come out and also our speakers. I also want to take a moment to thank everyone who took the time to organize this. We have so many people that I'm sure I've missed somebody and then they'd be upset. But there's a bunch of people in the lobby helping out with registration, food. There's I know there are people at the table with all the information, and we really could not do this without the whole village of people. So we appreciate everybody who's helped. I'm going to take a moment to let each of we've already somewhat met Dr. Tagizada as well as Dr. Roy, but I am going to take a moment for them to kind of go down the line and just really discuss kind of their aspect of why they're here on the panel. And then we'll start with questions, and I'll sort of guide the questions to various people. Okay? Well, we know he just talked. I'm going to give him a break. Go ahead.
So I have to follow him.
Okay.
Hi, everyone. My name is Antoinette Gujinska. I'm a PhD in clinical psychology from USC in Southern California. Spent most of my career doing assessment and diagnosis, working with my fellow psychiatrists. I'm currently the Vice President of Quality and Outcomes for Sandstone Care. We have several facilities here in the area. And we talked a little bit about processivity, you said, and I'm really excited about that because we do a lot of measurement-based care at Sandstone, so we're actually tracking the progress of our patients while they're in treatment, so that can also demonstrate for better outcomes, so the productivity. So thank you for that.
Oh, yeah, sure.
Okay. Hi, everyone. Again, I'm Durga Roy. So I am a neuropsychiatrist. My clinical area is on traumatic brain injury and concussions and psychiatric outcomes. I run the traumatic brain injury neuropsychiatry clinic at Johns Hopkins Bayview, but as you heard today, I'm also very tightly integrated with the Memory and Alzheimer's Treatment Center, so work a lot in geriatrics as well as neuropsychiatry.
Hi, everyone. I am Jenna Borelli. I'm a licensed clinical social worker, and I am the Director of Wellness at Bullis School, and I'm here today to represent adolescent and school-based mental health initiatives.
Hi, everyone. I'm Sharon Dietschy, and I'm the Executive Director of NAMI MC, which is the National Alliance for Mental Illness for Montgomery County. I'm also a licensed clinical social worker and have 30-plus years of experience working with children, families, and adolescents.
Thank you. All right. So who would like to start with questions? I know you guys have questions. Yeah, okay. And if it's okay, we can have people directing microphones, or if you can come, whatever is easiest.
Oh, so my question, I think, whoever, I guess, directed to Dr. Roy. Again, happy birthday. And I enjoyed both of you, the talks. But my questions are related to Parkinson's disease. I have a dad who was just diagnosed with Parkinson. So I wanted to speak into how that relates to is the Lewy body piece, right? Is Lewy body a form of Parkinson, or are they are they the same? Could you talk a little bit about that? Because
Sure. Sorry, is this, okay. Yeah. That's a fantastic question. So when there are kind of brain changes with various disorders, there are certain neurochemicals that are abnormal. You heard Dr. T talk about dopamine today. Parkinson's disease is one in which dopamine starts to get depleted, and then therefore, as you probably are aware, you see a lot of motor changes. So there is a lot of overlap between Parkinson's disease and this other entity called Lewy body dementia, because there are, again, similar areas of the brain. The difference with Lewy body is, first of all, there's a kind of prodrome that happens, which means like before the clinical signs develop, there are sort of things that we start to see early on before it's a full-blown dementia. And with Lewy body, we typically see a lot of things that are similar to a delirium, but is not a delirium. So there's a lot of fluctuation in alertness and awareness. They start to visually see things more, and there are motor signs, but it's not predominantly a motor disorder like Parkinson's disease is. Parkinson's itself also has its risk of developing its dementia syndrome. So as Parkinson's disease progresses, but I think the question was great today, but what does Parkinson's dementia look like? And that is, again, more problems with executive function, problems with sort of processing and planning. Lewy body is a much more rapidly progressing disorder, again, still affecting dopamine, but there are more neurobehavioral disturbances that we see, like hallucinations, more confusion, and sort of a changing in alertness and wakefulness. So I don't know if that answers your question.
Yeah, yes, and after that, I'm seeing all that with my dad right now. So my second question, I guess that's whoever on the panel, as far as the team, right? So we just discovered the Parkinson's. So now I'm trying to figure out, as far as managing his care, what are the doctors he needs, right? He has a neurologist, of course, he has a primary care physician. He's also seeing a psychiatrist, which I kind of questioned at first because I have other friends who have, parents or loved ones with dementia, and they were like, why is your dad seeing a psychiatrist? But from the talk here, I think that's also important to have on his team. So is there any other clinicians or doctors I need to incorporate in managing his care?
Yeah, so I love this question because the answer to this question really transmits to all neuropsychiatric disorders. I give all my traumatic brain injury families this advice. I give people with Parkinson's this advice, and I give any kind of neuropsychiatric or neurodegenerative illness. It's very important that a multidisciplinary approach be done, and that all the providers that are treating your father are in collaboration and integrated in the care. So you definitely need the neurologist, and specifically a movement disorders neurologist is who manages Parkinson's disorder. I mean, if you're able to have access to one. Then there is a neuropsychiatrist, so people who specialize in psychiatry, but then with neuropsychiatric symptoms of things like Parkinson's that develop. Those are hard to find. There's only a few of us in the state, but a psychiatrist that you have access to should work fine for now. But then also working with a rehab team. So we have a Parkinson's rehab center at Hopkins. And so integrated into that is OT, PT, and SLP. So speech language therapy, occupational therapy, and physical therapy are really integral in making sure that the prevention of the disorder and the disease doesn't rapidly come in a quicker fashion. So it kind of delays the progression of the illness. And then obviously making sure the primary care team person, or the primary doctor, is sort of the person fielding all of the coordination.
Okay.
Yeah.
All right. Thank you so much.
I'd also like to add that going through this, as you know, is a very difficult thing for family members and caregivers and loved ones. So I would also suggest that you and other caregivers in the family get some support through other, like support groups or even a therapist or counselor for yourself, so that you can talk through and maybe get respite and the support that you need around managing this. And NAMI, we also have a helpline that can help with getting you those resources.
Okay. Thank you. Thank you.
Yeah. Seth is coming with the microphone. Seth, can you? Oh, sorry. You're next, I swear.
My question's about female athletes in high school and eating disorders. My daughter was a competitive cheerleader in high school, and it seemed like a lot of girls were messed up with their attitudes in eating, and I just wanted to know, like, how often do you see that, and what's the typical, if there is one, like, path to recovery from having these issues consumed with feeling like you're fat when you're not, and all this, et cetera.
So actually, I'm going to direct that to Jenna, because she's probably one of the frontline folks as a at the Center of Wellness at Bullis. What are you seeing
Yeah, we can
at
tag team
Bullis?
this. I would say I've been at Bullis, but at any school I've been at, and I am a clinician that works at a school. I never thought I would work at a school. But working at a school, I always tell families that disordered eating is contagious. And once one person in the friend group is struggling with that, it very quickly trickles down to other people in the friend group, because they observe the behavior. And in the beginning, usually when someone is changing their eating patterns and their body changes, society really praises that. And what they see online and what they're constantly seeing on social media is also really praising that. And so it kind of gives a how-to manual, I think, to the friend group, and then it's a slippery slope from there. So first sign of intervention, I think, is noticing the one kid and stopping it there before it spreads. And if it is spreading, noticing, like, who is in your cafeterias at lunch that would even observe if there's kids not in there eating lunch. And how do we tell that to families while also letting kids have free choice at school? And so it is involving different stakeholders, I think, in the school community. And to notice, maybe that's the coach of the team, maybe that is the dean of students, maybe that's the cafeteria worker. But noticing it, and then how do you report it, and who's in charge of the reporting, I think, is the first line of defense.
And Sharon was vigorously nodding her head, so do you want to add anything?
I think what you said is absolutely true. It's very contagious, and it's always a fine balance of promoting healthy eating, but also not tapping into anything dysfunctional when it comes to the attitudes of eating. So it's a really delicate situation, and I think it's very important to get the guidance of experts. The research is changing, and our attitudes towards this 20 years ago is very different today. And so I would just suggest reaching out to professionals and finding someone to help guide you through this. Even if your child isn't directly impacted by this, you could get some help at home, because a lot of just things change, and I think that how we were parented tends to become part of our own parenting, our children, and even some of the slightest things that we may not even think are impactful can impact a child's attitude towards eating and their body image. So I think every parent, even the experts, need to be aware of this and continue to get the support and the information that can be helpful.
I think the other thing I would add is it's oftentimes how we approach it and how we talk about it, right? So if we're saying you need to eat more, and we're just specifically addressing that, that can also be really, really hard versus sort of drawing them out and trying to better understand what their relationship is with eating, why they're thinking this way. It's not uncommon and oftentimes very common that disordered eating or an eating disorder is also associated with anxiety or depression or some other sort of other mental health sort of thing. And if we're just looking at it from the lens of eating, we're not necessarily taking into account who the person is as well. And so I think, like everybody has said, is really sort of involving more people and looking at more of the constellation of everything, and also sort of looking at our own habits, because oftentimes parents will comment on the disordered eating of the child, but they're not necessarily acknowledging their own disordered eating or the fact that people aren't eating together, and really looking at what can we do to make this a more integrated part of where there isn't so much focus on food and calories and intake, and it's more about the experience. And the term that I use a lot, and this is again the term I use, is when it is an athlete, I also talk about eating like an athlete. And the importance that this is a little bit different because of your sport or because of things you need, not just the energy and the nutrition, but the ability for endurance, strength, stamina, all of those things that are important to be better. Your body's going to need that nutrition, and how can we sort of frame this in a way that isn't about eating more, but it's about also taking care of your body and your mind to be able to be as successful, because it's not uncommon that you'll see someone that has disordered eating disorder and they're a high achiever, right? And helping them understand that those things actually work against each other versus being sort of a quote-unquote healthier eater, and actually then being more likely to be able to achieve your goals.
I do want to add just one other thing that actually does not have to do with eating disorder, but is more related to disordered eating, which is that I think that depending what lens you're looking at the child through, like many people have talked about, there can be an assumption or, oh, well, that must be an eating disorder. Oh, they've lost all this weight. That must be an eating disorder. But just like Dr. T said, so we see in the hospital, we see a lot of individuals who are not eating and who are underweight and who are actually on the malnourished side of things because they have severe anxiety. And children really, a lot of times, and I'm talking about like elementary age children, middle school, certainly into high school, but anxiety can actually present as physically feeling unwell. And certainly, having issues with nausea or headaches, or they just don't feel like eating. And it's not that they have a classic kind of behavioral disorder that's an eating disorder, but it's actually a symptom of something more. So that is a good time to get someone checked out by sort of a general provider, actually, who can really look at everything first, and then if there's a subspecialty that's needed, like in an eating disorder, that could be something that's pursued. But I don't want to forget about all the many other things that can contribute to, that we worry about with the kids.
And I'd like to add one other thing. I think it's really important in the context of the world that we live in. This affects both boys and girls, but especially girls in that, we're seeing the rising cases of it happening in boys, but it's in the larger context of the pressures that girls go throughout their life regarding their appearance. And I think that that's an important piece. I think it's great that you're staying ahead of it, and just being able to talk to your daughter about, or our children about this ahead of time so that they're aware of it. I don't know that there's many groups of friends who this, especially with females, that this isn't being discussed, and it's coming from every angle. So just trying to stay ahead of it as best as we can, it can be very helpful.
Antoinette, did you have anything to add?
The one thing I think I would add is the microcosm of the friend group, right? It's really become more of a macrocosm with social media. And I think what draws people to social media is what both of these doctors mentioned today about healing these disorders is through connection. And we approach social media for connection, but it ends up becoming comparison. And I think a lot of times we have these influencers who are unfortunately influencing us to try other behaviors and maybe start, the cascading effect of that. So just taking that to the larger issues that we're seeing today with our young people and how they're being influenced from social media can have an impact as well.
Thank you. I know there was a question down here, Seth.
Thank you so much. I serve in long-term care, memory care facilities, and socialization and connection are two really important components that I heard you bring up in your presentation. As these episodic memories begin to fade, and as families are navigating anticipatory grief, what are ways that we can help our family members connect and socialize with those who are under the umbrella of dementia?
Yeah, so as you point out, it's critical to have that. So one of the things that has been very helpful that we've heard about sort of from a systems perspective is facilities starting to think about creating, and there are, I think in Europe, I feel like there may be some here in the US, facilities where there are actually designed to recreate the real world experience. So you'll kind of go out of, instead of being in a hallway, for example, that's like, you know, a regular hospital hallway or a nursing facility hallway, it looks like it's outside in a park and you're walking and, you know, there are shops here and sort of getting people kind of acclimated to what a real world environment would look like. Obviously these things take a lot of money and a lot of resources. Music therapy has also been known to be very helpful in sort of not necessarily bringing back. So one thing we want to be clear about, because it's a neurodegenerative disorder, is we're not going to have our family member be able to go back to who they were before the dementia started, right? But we can certainly slow down the progression of it happening with these interventions. So the goal isn't necessarily to bring back episodic memories or to bring back things that were lost, but it's to sort of, number one, prevent the rapid decline, but also kind of improve quality of life. So part of that is bringing back familiar things from the family. You know, the family can provide music that was once very enjoyable for the individual, or, you know, photos of people from when they were in their childhood or they're having their upbringing. And then, like I said, sort of building simulation communities in these facilities that can really kind of help trigger some of the excitement and ability to sort of use different skills that they may have started to lose in their phase of dementia. I don't know if that answers your question.
There's so many OTC meds to promote brain health. Can you make sense out of all of them? I mean, sometimes they bring a bag of them and like, where in the world did you get all this? Any?
Sorry, Dr. Roy, that's you.
Yeah, I figured as much. Yeah. So I always bring it back to the FDA, and I say, well, this is over the counter. So sure, it's St. John's wort, not an example of brain health, but let's just using it as an. And we don't know what's in that capsule, right? We don't know, like, it's not regulated. We don't know exactly what these supplements have in them. There's a large area of research that is going on that looks at nutraceuticals, so certain agents like vitamin E and other, you know, and I'm not by no means an expert in this, that are being explored, but they haven't had 100% full, you know, trials that have been done on it. So what we do say is that for prevention, for sure, it's obviously, you know, exercise, Mediterranean diet, and things that normally you would use for maintenance of health, you know, elements that we usually use, magnesium, zinc, and those kinds of things. These kind of supplements that have adaptogens in them and other kind of components that potentially alter cognition have not been studied at all. And so typically I advise patients, especially my brain and my TBI patients all the time are saying, you know, I just had a concussion, can I take this? And is it going to reduce the chance of me having any memory problems? And I say, it's not been studied in TBI, it's not been studied in dementia. So I try to sort of steer clear of that. And if it's something over the counter, I do point them to the risks of potentially being something that's unregulated.
So there's no one OTC one that you recommend per se?
I definitely don't. And again, it's a individualized kind of decision, and also it's an evidence-based. What we do know, for example, omega-3s are very well studied to know, and we know that they help, right? So fish oil or krill oil can be something that we know is an established intervention for brain health. But again, it's something that's been historically used, and it's nothing that's just new on the market. Things that are newer, I would be more skeptical about. So I wouldn't really.
Any thoughts on Prevagen? Is that the number one thing that I get so much?
I haven't. Have you?
What is,
Prevagen?
Oh, no. So I certainly, I always have something to say. I'm really trying to keep my mouth shut. So, but I will say, so one of the things that I notice is that, okay, so my husband is not in the medical field. And he thinks his Google MD is better than my actual MD. It's quite frustrating. It's caused a lot of marital conflict. But he's always looking at all these supplements and things like that. And I think that there is this want, of course, to prolong life, to fix ourselves, to like do it, especially for people who are highly functioning, people who are like, well, I don't want to go, I want to fix this myself, you know? And what I have actually found is over-the-counter does not equal safe. And I think that people make the assumption that, well, if it's over the counter, I mean, anybody can take it, so it's fine. And so I just caution people, because not only is there not necessarily good evidence-based data to show that it's helpful, the actual medications are not FDA regulated, meaning you don't know exactly what you're getting in some of the supplements. In addition to that, they often interact with prescribed medications. And so people don't recognize that while they're taking the bag full of supplements, it's actually interfering potentially with other medications that they're taking, and they can also have hidden ingredients like caffeine or stimulating things that can cause problems. So I always ask people everything they're taking, and then they don't tell me about the over-the-counter stuff because that's their own private life. They don't need to tell me about that. And then I say, no, tell me everything you actually put in your mouth. And then we kind of get to a full list of all the herbals and the supplements. And with younger folks, that's really important with the younger folks and all these different performance-enhancing things that they're using, and that elevating anxiety. So I get really into the nitty-gritty about all of those things because it can have a negative impact also. Yeah.
Can I say one more thing? I think the other thing is we don't know, like just young people, right? Like the way people access information. Like oftentimes, like I don't even know how they found that and how they do this and they got my password and they use. They're very, very, very thoughtful about how they get information, and that can be a problem because they often have information about things and supplements that we don't know about, but because we don't know about it, we're like, well, we don't know about that. But there's a lot of things that people take that are not necessarily illegal, but they're unsafe, and it's sort of under the guise, but there's a lot of health and wellness implications, and I see that consistently where a parent will say, well, they took, Kratom, like it's online and blah, 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 and then I'm like, do you know what that is? And they're like, no. And then I talk to the pediatrician, do you know what that is? They're like, no. And I'm like, let me tell you what it is, right? It can cause like hallucinations and psychosis and, delirium and all these things, and they're like, wait, what? But they just got it online. And so I think it's, to Dr. Bone's point, to everybody's point, it's important to just ask and ask and ask, because then we can sort of have those conversations about, look, just because you got it online or you got it at this place doesn't necessarily mean it's safe. And just because your friend takes it doesn't mean it's safe for you. Because not everything that everybody takes, everybody responds to the same way. And so that's the only other thing I will point out is sometimes when we don't know, we don't want to know. And that's when we should start asking questions so that we can better understand.
I want to say one thing, and I had a patient who was taking the medications, and they were all over the counter, so I didn't even know what the person is taking. I went through everything, patient is getting sicker and sicker. Finally, I called the neurologist, and I ended up looking for all the medication. It was not even the medication. It's the fillers of these over-the-counter medications. So those fillers we don't know. And none of the medication is true pills, true ingredient what we are taking. It's the fillers also. So these fillers are also a problem, which as a physician we don't know. And we finally found out that patient was getting sicker and sicker, and we did everything, and finally we found out it was the fillers. Once we stopped all the vitamins, all those nonsense, I say, patient started getting better. So whenever we put something in the mouth, we should understand. If it is not food, it is not what you are used to taking it, be careful.
Just a second.
I have two questions. One is what you're already talking about. I do go to a nutritionist, but she also happens to be a physician. So I trust what she does, but I wondered if websites overseas, if any of you have a suggestion. I wouldn't necessarily trust some of the websites here in the U.S. Do any of you have suggestions as far as what you would use websites overseas? For instance, Germany. I get information faster from Germany and also UK.
I think we're hearing radio silence up here.
Okay.
Yeah, I don't have a comment about that. Yeah.
All right. My second question is that I have a sister who is the beginning of dementia. Her family, really, they don't understand or maybe don't care as far as caretaking. This is a time when I don't live near my sister, and some of her children do not live near her. Some live right there in her house. And I know that you have to want to do something. Is there anything that you would suggest that would be a positive thing for the family to encourage them to be better caretakers?
So I actually am wondering, Sharon, do you want to answer that question?
Sure. Has the diagnosis been made yet?
Yes.
Yes, okay. I would suggest, just as the person who's receiving this diagnosis, the caretakers and family members, loved ones, also go through a process. And sometimes accepting a big diagnosis, there's a lot of denial, and, they have to go through their own process. I think this is fairly normal for a family going through this, that it's not, I wouldn't say that they don't care, it's that they have their own defense mechanisms and resistance that's coming up that's sounds pretty normal. I would suggest that maybe they join a support group or get some information about this process of accepting a diagnosis in general. Maybe some of the groups that specialize in dementia can offer this. But I think that with maybe your help and other family members guiding them that this is normal process, that this is a normal process, and helping them through the beginning stages of this could be helpful for them.
I'm going to go ahead and add to that one too. This is just my experience with seeing this a lot in a hospital setting. So where I come in a hospital setting is that a lot of times families come in if there's some kind of medical issue that needs to be addressed, or if the dementia has progressed to a point that they can't safely take care of the person at home and they don't know what to do. So they bring the individual to the hospital. So that's where I kind of intersect. And what I've discovered is often, just like was mentioned, if you're living with it every day, you might not see it, or you might explain it away. Oh, well, they're just getting older, so of course they're losing their keys, or they're just getting Jane did steal money when they were 12, so yeah, of course they're going to think that money was stolen out of their wallet. So they'll explain away a lot of the symptoms. Personally, I think what is most helpful is to give concrete information. They know this. Okay. Usually I like to convey it with like a number. So a lot of times we'll do like cognitive testing that's like a MOCA or a mini mental status exam. And I'll actually tell them what the number is and what the number means. And then, we'll also talk about the progression. So they're just educated about what to expect. And every family is different about when they want different supports to come in. Some family members are like, I am never sending my loved one to any kind of nursing facility. I mean, they've just decided they are not going to do that ever, no matter what. And so we kind of talk about the wraparound supports that are helpful. As somebody who has taken care of my mother-in-law, she did not have dementia, but she had a lot of medical problems. And her daughter lived in Kenya. I was very frustrated that her daughter had a lot of opinions about what to do and she wasn't there. I'm just going to say that out loud. And I'm only saying that because it might be helpful if you can offer some kinds of support. It's really hard to be in that house, just as a comment.
Can I add to that?
Yeah, please.
So we did research specific to this at USC, and one of the things that was a strong takeaway for caregivers is when they are participating in those types of support groups like NAMI offers, is the takeaway for them is, I can be of great support to my loved one if I realize that I need the support too, that I'm just as important. So if I don't take care of myself, I can't be that support to them. And it's a really strong message, especially for those usually moms and wives that are stuck in the middle, that we care for everybody and we never think about ourselves. And so to avoid caregiver burnout, that's one of the strongest messages they can get from a really effective support group.
It's a tough situation to navigate, for sure. A question up there, and then I know Mr. McMahon has a question also when you're done up there.
Hi, I was just going to ask the school wellness provider to talk a little bit about some of the red flags that you're seeing in your environment from a mental wellness perspective.
Yeah, I mean, I think that's a different day to day, year to year. Every day there's a red flag about something. But I would say red flags, like trends that we have. So anytime a student comes to see us in the counseling office, afterwards we take a note about it. And that note we can tag at the end of like anxiety, academic, home, risk, like why the student came to see us. And then I can run live time analytics to see what's happening within our school community, K through 12. And then we can design intentional advisory or social emotional learning programs to address the trends we're seeing in live time. So that's kind of a unique way to kind of track what's happening. I would say the red flags is, and this is probably not new news, but like achievement at all costs. Like the young people, even starting in middle school, starting to think about building their college resume and thinking that what they are doing and what school they attend will determine their life. And really going against that narrative of it's not the institution you attend for college if you choose to go to college, but it's about those like skills that we heard about earlier about building grit and like you being a hard worker, you entering any room and realizing you can learn from someone in it and modeling those types of behaviors early on, because it's just creeping younger and younger around that achievement and building your resume to be this shining star so you can go off to this highly selective school and then your life is okay. And it's just false narrative that we're selling kids, but it's the water that we're all drinking, and how do we tell them that this start swimming upstream, because this is actually not accurate information they're getting. So I would say that's one. And then the other piece is around perfection. It's kind of tied with this. A lot of our girls, and Bullis' enrollment, Bullis started as an all-boys school and a preparatory school for the Navy, and not until 1981 did it become co-ed. And we still have our enrollment is 55% boy, 45% girl. And so a lot of our girls really struggle sometimes to find their voice and think for their voice to be valid, they always have to be right. And then, or they have to be perfect or know exact thing to say, to speak up. And so empowering young women to take up space, even if it's not exactly perfect.
Oh, thank you. I have a comment, something I did. I have a sister in California, and she's 97, and her memory's slipping away. When we were teenagers, I was the dance party dummy. I learned to dance because she wanted to dance, and she was very big on music and all that. Just recently, PBS had a stack of CDs that they were selling with music that came right from that era. And so, well, it's they could get a calendar. And we sent that out, and she responded to all that music and was tapping her feet to it and understood it. And I sent 2 packages, one out for the care center that she's at, so they can play that for everybody that's there. But I think that's something that's quite powerful, really, because that gets the brain working when it's not working. But that music never goes away. I even know when I'm listening to something, I've got these songs just memorized up here. So just a thought, but I think that is it's a real positive for these elderly care people. Yeah. And I remember my father tapping his feet to Pennsylvania, 25,000, whatever it was, all those things. But he was big on the music of his time, and it was a real help. So just put it in the pot there and use it.
Yeah, and thank you for that. So that the music therapy that I was referring to is exactly that. So you're doing music therapy, which is great. keep sending those CDs over, because it's exactly going to do what you saw. It's going to trigger a lot of not episodic memory, but some procedural and declarative memory. So that's great.
Is there a reason? Because I do want to make sure we address one thing for sure, which is that we've talked about the stressful environments of the kids. We've talked about certainly the older population, the stressful environments with the kids. Something that I am asked on an almost daily basis is about when the kids get to a point where there's a concern or a flag, where do you go and what do you do? So I'd like to just go down the line. Whoever wants to start first is fine. I'm not going to pick on anybody. But talk about if you do feel like you have a kid that's in trouble, because some people don't recognize there's actually a very large spectrum of psychiatric services and mental health services. And so I want to make sure people who are here understand that there are different places to get help and where to plug in depending on what kind of help is needed.
I can start. If that happens, contact NAMI. There's NAMI, just to explain what NAMI is, it's a national organization, and we're in every state, and NAMI Montgomery County is the local affiliate for Montgomery County, and most areas have a NAMI. If you have any questions, you can contact our office if you don't live in Montgomery County, and we offer support, education, and advocacy for people. We have 2 tracks of programming, one for people with mental health conditions, and then one for family members and caregivers of people with mental health conditions. And it was originally started by caregivers, and we also have resources. So we have a helpline, and if you email us at info@namimc.org. We have information on the table outside. We can help direct you to getting the resources and the help that you need. That's why we're here, and that's a big part of how we serve the community. So if you have a question, you may not know what's going on or what's happening, that's where we can come in and help you. So please don't hesitate to reach out. That is why we exist, is to help support families, especially when they're in the most difficult, confusing time, is when things start to percolate. And so please reach out to us and we can help guide you. It may not be a direct line. It's a lot of going back and forth and all of that, but we can be there with you to offer you the help and support that you need during that time.
I can give a little preface to this. My career has been greatly impacted by suicide. I was living in Palo Alto and fresh out of graduate school and working in a school district, or in a community where we had 10 kids die by suicide the same way in 16 months. And the whole community was traumatized. And my job at the time was working at an intensive outpatient program where kids would leave Stanford Hospital and come to our program because they'd made attempts at ending their life, but survived. And so I was working there for years doing individual and family therapy with kids that didn't see the purpose in living anymore. And through that, after like 3 years, I was like, I cannot just keep working with kids that don't want to be alive, and we have to have a better prevention model, and hence what led me to work in schools, because I really believe that with young people, they're in this place all the time. Most of their day is spent at school. And who are these people that notice, and what are the policies and procedures of how do we catch kids, to this question of like the kids with the red flags, how do we notice? And I think my tip for anyone is be curious about the district or the school that you're going to. Ask that question. What policies do you have in place to catch kids that aren't doing well? How do you know? And if you do hear something, what do you do about it? Who alerts the family? Who's in charge of that? What secrets does your counselor keep that the kids are telling them? And what's our barrier of, I can't keep this secret and I need to tell other people? And be really curious about the communities where your kids or grandkids are and what their policies and procedures are. Because I think if we know our kids at the place that they're at most of the time, a lot of prevention can be done so that hopefully our young people aren't at that point where they're saying life isn't worth living. And I want to attempt to take my own life. So be really curious about your school and your community and what policies and procedures are in place. And if they are funding, like having counselors at the school, what does the funding look like for wellness programming? What is the backlash in your district or where you live around social emotional learning? Is that being taught? Is that being banned? Just be really curious with your school leadership.
Antoinette, did you have anything?
I think I'm back. Oh, good, I'm back on. I think a really good takeaway is to know that different facilities in the community are often interlinked. There is a webbing and a networking that takes place that people don't often see. And I've been working in the private sector for some time now, but I've always had the great pleasure of working with treatment placement specialists. We have one here, Danielle, and her job really is to let the staff here know that Sandstone exists and we can have an opportunity to co-refer back and forth. And so it doesn't stop there, because the leaders in the hospital situation like this can also reach out to other facilities out there with the school systems, with other communities. And if there is a need, a parent can reach out, a partner can reach out to their doc, and their doc will say, you know what, I'm going to call Danielle to see what's the best place we can place your loved one. And she does the heavy lifting. She knows exactly what to ask those questions and to help guide you to the best treatment possible. And I have gotten calls on Saturday mornings from treatment placement specialists saying, Antoinette, we need help with this one particular patient. Where should we place them? And something, if it's not with our hospital, they're going to find the right one. And I think that's the biggest, strongest takeaway, is we really are working as a network behind the scenes. So you just start by asking. Start by asking a provider or your neighbor or your loved one, and they can get you into that path towards healing.
And then, since I always need to say something like Dr. Bone as well, I agree with what everybody said, and I'm a clinician, so people come to me for this, and oftentimes people say, it's so hard to get into care, it's so hard. And so knowing the resources and knowing the people that are doing that is incredibly important. But the other thing is knowing that you can also make an impact, right? A lot of times, I hear from parents and coaches and teachers, well, I'm not a mental health professional, I don't understand this stuff, or I don't struggle with anxiety, so I don't know what to do. But inherent in that person who's struggling is still a human being. And you know that person better than anybody else knows that person, right? Like, you know them. And so part of it is helping them feel connected rather than focusing on who they are as a student or who they are as an athlete, or rather, I should say, what they do as a student, what they do as an athlete, and all those things. Sort of just being curious, that word came up, right? Being curious, asking questions, even saying, help me understand what you're experiencing. Help me understand what's difficult for you. Help me understand what's challenging. Help me understand how I can be supportive. Sometimes even talking about that at home, where they should feel the safest, and sometimes they just feel the most misunderstood, right, can make a huge difference, and then allow, first of all, buys you a little bit of time to then find out what the resources are, but it also allows that young person to feel connected and feel like they're not being judged at home, and then they are being loved. And those are important things. There's an organization that some of you may have heard of called Morgan's Message. And Morgan's Message was started by a family in response to her daughter, who was an athlete, a Duke lacrosse player who died by suicide. And I had the pleasure of meeting Morgan's mom. And I spoke to her on the podcast, and she said, Dr. T, we talked about everything at home. We talked about sex. We talked about drugs. We talked about alcohol. We talked about everything that could affect a young person, except for mental health. Because we didn't know that we were supposed to talk about it. We never had the conversations. And she said, I can't help but think that if we had some of those conversations, if we checked in, maybe things would have been different. So I also think that you don't have to be a mental health provider. You don't have to be an advocate. You don't have to be all that. But if you're willing to ask questions, understanding you may not have the answers, and you're going to hear some scary stuff, but that also allows that person to feel comfortable opening up. You're already starting that process that they can feel comfortable opening up, and they're not going to be judged, and they don't have to worry about what they say for fear of the consequence. Now you start to set that foundation that it is safe to talk about things. It's empowering to talk about things. There's strength in being able to name these things, to talk about these things, and then you can also then sort of get more information and also help draw that person to it, right? Because you still have to bring that person to the treatment. And most of the time we want them to come willingly, right? That's the best outcome. So that's the other thing, is just knowing that everybody in this room, you know, no one's going to care about your young person as much as you are. And so start by really showing them you care and listening to them, and just being more inquisitive with the questions versus figuring out you have to fix it and have all the answers, because that can make a huge difference.
And I will say, if there are ever any thoughts about ending their life or suicide, get them help immediately. I love NAMI. Don't wait for NAMI to respond by email. I mean, actually get them to the emergency room. So, but know what the emergency room can do. So we have an emergency room here. We have a peds and we have an adult emergency department. We see people in crisis. We have actually our head of crisis who's here right now. Thank you, Janae. But we don't offer psychiatrists in the emergency room. We have a crisis social worker in the emergency room. We have families who come in and want their child to be put on medication in the emergency room. That's not something that we do. We really are evaluating a crisis and determining if that child needs to be in a hospital setting to determine if medications need to be started or something else needs to happen. It's not always about medication. But I just like to say that because I think some people don't understand like what happens in the emergency room, you know, how does that go? And that is definitely the place to go if there's a concern that someone might take their life. That's the place to go. You can also, the other thing we've been trying to tell kids is that, you know, kids don't want to talk to anybody. They want to text people and do all sorts of things. And so now the suicide hotline is it's not a suicide hotline, it's a crisis hotline. So you don't have to be suicidal to call. You can just not feel good. You can just you want to talk to somebody and you can call. But it's not even calling. You can text them. So it's 988 and you can call them or you can text them. So I try and give that to everybody. They made it a lot easier to remember by just making it 3 digits. So you can text them, you can call them, whatever. But I tell everybody that so that the kids can text. I mean, I've had the number of kids that have texted 988 is unbelievable. I have not yet heard of a kid calling. So, yeah. Any other questions before we wrap up? Yeah. I think she's right behind you.
Thank you. My question is for Dr. Tagizadeh, actually. Well, since my first child was 6 years old, until now that my 6th grandchild, which is 6 years old, we, involve them in sports. And not serious sports, but we knew that it would give them discipline and help them, really throughout life. What I have noticed, it is that by standing just on the sideline, and I am very involved in their sports life, watching them at least 2 games per week, it's the parents and the stress that they put on the children on the fields by coaching them. While they're having fun, they're supposed to have fun. A 6-year-old child does not know much about the techniques of soccer ball. So how could you mute these parents while they are having fun rather than turning it into a competition that their lives depends on? So, thank you.
It's a great question. I mean, there's a lot of things you could do to mute them, but probably the healthiest one, I think that most parents do come from a well-meaning place. I want to believe that they truly want the best for their child, and they want to motivate their child, and they want to inspire their child, but they don't know how to. And so, part of it is helping them understand that your child will have several coaches throughout their life, that will have several teachers throughout their life, but they're only going to have one parent. They're only going to have one parent. So be their parent, right? Be their parent and help understand that the more you coach and the more you talk, the more actually they shut down because they worry. They worry about disappointing you, and then all they're hearing is your voice, and then they're also worried if they don't do something. And so I think that a lot of parents don't recognize it and don't realize that they're actually adding more stress and more pressure, and their child's going to shut down. I recently spoke with a gentleman. I was at a college lacrosse game. I'd worked with his daughter. I was sitting with them, and he coaches youth hockey, USA Hockey, and he's in charge for all the development. And he was talking about the percentages of kids, like 80% of kids stop playing, again, US hockey by about the age of 12. And when they did the research, the number one reason that they cited was the car ride home. It was the car ride home, right? And that they dreaded the car ride home, and they dreaded talking about it, right? And I actually have a parents' talk, and it's called Don't Say Don't, because parents love to say, don't do this, you didn't do this, right? So part of it is helping them understand if you want your child to be their best, and you want them to be the most successful, and you want them to have the most fun, which is going to help them be the most successful. Take a step back, allow them time, just enjoy the fact that you get to watch them play with other kids. How fun is it to not have to work, to be able to sit there and to just be able to take joy, right? I imagine you take so much joy and pride in watching your kids, then their grandkids. It's an ability to truly stop life and how difficult and complicated life can be for all of us and just watch kids being kids, right? And that's a valuable message, but it also translates to success. And it's helping them see that this isn't just about being passive. It's actually facilitating your child to learn, to be able to enjoy, to interact, and to be able to find their own voice. And that can make a big, big difference, but it's hard, right? Because people just can't stop talking, right? Including myself.
Can I add to that? I would also just add, so my husband is a Division I coach and has our kids have grown up watching him win at the highest level, winning a national championship. My oldest son just started that sport that my husband coaches. And going to the games, he intentionally sat in the back row and didn't say anything. And we had talked about this as a family before, we're gonna go and Dad's gonna be there, but he's gonna be sitting in the back row and not say a word. And Coach Elijah is your coach, and you need to be listening to Coach Elijah. And so many of the parents had a reaction to that of why aren't you saying anything? How are you controlling yourself and not up there yelling? You obviously know more than, whatever the middle school coach is. And it was my husband's response was I want him to learn to have fun through this sport without me being his coach. We coach him in every other aspect of his life about raising him to be this person we want him to be, and learning to hear other adults and trusting other adults to teach your kids these lessons. It changes the whole parent dynamic on the sides because they realize oh, he's not doing this and he says this is for a living. Maybe I don't need to be yelling constantly either. So it's also kind of encouraging your micro communities of one person saying, we don't need to parent like this or lead like this to show that we're engaged. And I think that is just a lesson you could do just with your one team, because it's hard to think about it as a big picture because I think it's a big societal problem.
I have a little story to tell as well. So my son played soccer, and since he was 3, and we had the same problem. Parents screaming what plays to play, and they're yelling at their kids from the sidelines. And I don't know how this happened, but the referees for this particular league actually would red card parents. So if the parents were not being parents and they were interfering with the coaching, the referees would come and give them a yellow card or a red card, and it really helped to really set the stage very clearly.
All right, I think this is our last question.
Thanks. When you were talking about that, I have a nephew when he was on the baseball and he loved it. And briefly, they lost. But it was the coach who sat there and talked to them, and my nephew walked off that field thinking they had really won. And I thought that this happened over 30 years, maybe more. And I just thought that was a beautiful thing coming from a coach. And it really was the essence of what sports is about. Thank you.
I want to thank everybody for coming this morning. I really appreciate having everybody here and having all of our panelists and our speakers and having our families come and having Mr. McMahon and Ms. McMahon come and all the different clinicians and families and all of that come. And I hope you all enjoyed this morning. Thank you.